Good evening, sir.
Good evening,
Sir,
sir.
good evening, sir.
Good evening.
Good
Just a
evening,
minute.
everyone. Good
Okay.
evening.
Good evening, madam.
Good evening.
Good evening.
Good evening.
Dr. Kanaram has just sent a message that he didn't receive the link.
Yes, I have sent in the link. I'll just share my presentation. Everything is all right. Share. ओके कौस्तुभ आ गए ठीक है ओके रश्मि आ गए एंड
Ankit is not there.
अंकित इज नॉट देयर ठीक है सो फर्स्ट कौस्तुभ को आइए तो आई थिंक वी कैन वी कैन स्टार्ट
Sound. Yeah.
Sure,
कौस्तुभ
sir.
गुड इवनिंग
Good evening, sir. Good evening, ma'am.
तो
Good evening.
good evening, a warm welcome from IAPNRC Respiratory Chapter. Respected Dr. Rashmi, Dr. B.A. Sharma, Dr. Sushant, Dr. Rashmi Randan Das, all the EB and OB members of IAPNRC and all the delegates who have joined today evening. We welcome you to this last webinar of 2025. And in this webinar, we have decided to discuss a very important chapter, which is a current topic of discussion, particularly the management of acute cough. As you all know, there had been unfortunate deaths in MP because of the use of a cough syrup in children. Although the cause of death was contaminant in that cough syrup, which was diethylene glycol, which was an industrial grade solvent, which is basically a sweetener. It's added in all the cough syrup, but basically it was a contaminated, and that led to all the uproar. And then there were a lot of flurry of cases against the doctors in MP, and then guideline from the government, and then from various organizations that what is the role of cough syrups in children with cough. So we decided to have a CME where we would discuss the issue of acute cough in children. We'll discuss the OTC formulations, different component of OTC formulations, and we see what is the exact role of these formulation in management of cough. And then at the end, we'll have a panel discussion where we would discuss three very common case scenarios which I have treated in the past 1 month. They are all routine cases, nothing very tough or complicated, but they all have issues where practitioners they commonly use OTC cough syrup. So our basic aim of this panel discussion would be to give you the insight where are these OTC cough syrup indicated in this session, because they are very common, whether they should be used. If they are not to be used, then exactly how do you manage these cases? Because you know, if in this particular season, in winter season, in your OPD, out of say if you are seeing about 10 cases of respiratory infection, out of them 8 would be viral respiratory infection which get all right without doing anything. But because of lot of parental pressure, the child not getting better, you are tempted, you are sometimes forced to add some cough syrup, or already they are already giving some cough syrup, then you have to tell them please stop it because this is harmful. So there are a lot of issues, management of these all problem, because what I feel is that management of a bacterial pneumonia is easy. You know the response is predictable. You diagnose a bacterial pneumonia, you give antibiotic, you get all right in 3 days, everything is fine. But if you get a child with viral bronchitis, you don't know what turn it will take. It might get all right without doing anything. It might go on to have a viral pneumonia. It will develop something like viral sinusitis, something like otitis media. So it is absolutely unpredictable. The course can be prolonged, got all right within 3 4 days, take about one month to get all right. So there is a wide range of a normal course of a child with a viral cough. So then you are tempted to do things which you should not do. So in today's CME, we'll be going to learning. We'll learn all these issues where how do we approach this common problem. What we have done is that we have taken top pediatric pulmonologists in this session. Now it will be just like trying to hit a fly with a bow force. These all are very senior people and they will be managing very simple cases. The aim of having these people on board is that they will add weight to whatever statement they will be giving. So if they say that you don't need to use bronchodilator in case of bronchiolitis, it is a final statement. You don't need to think much that kare, use or not use. So the very reason we have kept very senior people on this team is that whatever they'll say, it is backed by their vast experience in pediatric pulmonology. They have got, and whatever they say, it is evidence based, and there is no much need to discuss whether we should use or not use. That's why we have kept very senior people, and let us hope that by the end of this session, we'll have some very important take-home messages so that we can manage these cases in a very evidence-based manner. So to set the ball rolling, we have got first speaker in form of Dr. Kaustubh Mohite. He is a young pediatric pulmonologist from Navi Mumbai, and he is an interventional pulmonologist, and he's a young, dynamic clinician, a very good speaker, and he'll take us through management. What is acute cough? What are the various causes? How do you manage? He'll give us a bird eye view. He'll not discuss individual problems, but he'll just give a bird eye view how to approach a child with acute cough. Following that, we'll have two talks on OTC cough mixtures, and at that we'll have panel. So I'll request Dr. Kaustubh to share the screen and start his presentation.
Right. Right. So before I start, I thank Rawat sir and the IIP chapter, respiratory chapter, for giving me this opportunity. Is my slide visible?
Yes,
And
make it full
am I am
screen,
I,
please.
am I nicely audible, sir?
Yes, yes.
Yeah. Okay. So I'm Dr. Kaustubh Moite. I'm a pediatric pulmonologist from Navi Mumbai. So before we start, let's start with something interesting. Any idea what is this? This is a pufferfish found in the depths of oceans around Japan. It's been said that it actually measures not more than 2 to 3 centimeters in its normal dimensions, but once it faces danger, it can gulp in almost 8 to 10 times the amount of the air or water, the amount of its body, so that it swells up. And in this process, it damages so many organs within, and it's told that it has n number of fractures. The bony structures undergo many fractures, but this is just as a way of protecting itself. So just keeping that as an example, that what looks to be hazardous or harmful is actually protective in nature. In the same way, cough is normally a protective reflex. The main function is as a mode to mobilize these airway secretions, but this excessive cough indicates there is some amount of airway irritation. Just to make it very easy, an acute cough is labeled which is less than 3 to 4 weeks, a chronic which extends beyond this time. A bit into physiology of cough, this mainly phase comprises of 3 phases. First is the inspiratory phase, in which you breathe in air, you fill in your lungs. Then there is a moment of glottic closure, in which there is some air which is building up pressure inside your thoracic cavity or inside your lungs, and you release your glottis so that all this air gushes out with significant velocity, making sure it's mobilizing all its secretion. So cough need not be always pathological, or cough is more or less a protective reflex to make sure that all these secretions are pushed out of your airway. Now, there are various receptors all across your airway, starting from your eardrum and canal, going all the way to your alveoli. The density might be different, but they are mainly situated all across the airway, and even in your extra pulmonary regions, maybe in your GIT or even in on your diaphragm. The main afferent nerve is your vagus nerve, which goes and stimulates your medulla oblongata, and efferent forms in the form of various nerves like your vagus, spinal neuron, and phrenic nerve. And finally, acts as the cough it is. These density of cough receptors, as I said, more or less we can grossly say They are high towards the proximal airway, and as we go down, the density of this cough receptors relatively go down. So a disease in which there is cough predominant points us towards something which is more proximal airway disease. Once it goes downwards, the cough might decrease, but intraparenchymal lesion comes in the form of tachypnea or respiratory distress. Now, with this, I would like to keep this approach towards this cough into three main types. First, we'll see something like a case-based approach. Second, a small questionnaire-based approach. And finally, third, make it very simplistic into an algorithmic-based approach. So first, let's go towards something like a case-based approach. So with this, we'll see four typical cases. It's very straightforward. So we don't want to jump to the diagnosis or the treatment part. We want to first differentiate what are the different etiologies of acute cough. So first is a 6-month-old child, complains of runny nose for 3 days, cough for 2 days, low-grade fever in the last 24 hours. Cough is intermittent, occasionally wet sounding. Otherwise, this child is active, playful, is feeding well, and there is similar complaints in the mother. On examination, the vitals are stable. There is some nasal secretions. Respiratory rates around 35, air entry bilaterally equal, and occasional wheeze are heard. This is one of the commonest stereotypical case that we see in our OPDs. Just keep this case in mind. Coming to our next case, this is a 6-year-old child. Cough is now for 4 days, breathlessness since the last 24 hours. There is no fever. The initial child had fever. This child doesn't have fever. Cough is dry, predominantly nighttime, increasing on exertion, associated with some nose block or sneezings. There is some disturbed sleep, had similar episodes in the past requiring nebulizations. This child has baseline tachypnea, significant mouth breathing on presentation. Air entry is bilateral equal, bilateral polyphonic wheeze is heard. So we know what the diagnosis is, but we'll just keep it for now. The third is a 3-year-old girl child, sudden onset of cough, breathlessness, was well some time back. Sudden complaints were noticed after she was eating something. Cough was continuous. There is redness of face, increased secretion, child is tachypnic, air entry decreased unilaterally, and significant wheeze is heard. We know the diagnosis. And finally, this is a 14-year-old girl, an old child, complains of cough for the last 2 weeks. No other complaints. There is no breathlessness, no fever, no aggravating factors. The cough is intermittent, but all throughout the day. No cough once she goes off to bed. Had similar episode 6 months back. And on questioning, you see that the exams are coming up in the next 1 week. This child is well, vital, stable, air entry bilaterally equal and clear. So these are 4 very stereotypical cases that we very well see in our OPDs. And the first approach which I want to keep forward is the 4I approach. Differentiate between infection, inflammation, ingestion or aspiration, and idiopathic. So we know, let's not get into deeper into each of these, but let's just see how can you pick up these just by history and your first general examination. So this infection most likely could be viral, involving upper airway as well as lower airway, starting right from your nose. So rhinitis, followed by sinusitis, tonsillitis, pharyngitis, epiglottitis, to make it just differentiate into 2 very easy, either upper respiratory or lower respiratory. Also to be noted that even otitis media can also give rise to cough. Even normal wax, if accumulated over a period of time, could give you something called as otogenic cough. So that also needs to be taken under consideration. So your URTI most likely could be viral. And as discussed previously, upper respiratory tract have significant high density of cough receptors. So it's a cough, there is significant cough. So if it is cough predominant problem with some sore throat, some rhinorrhea, occasional ear pain, lung findings may or may not be present. A lower respiratory tract could be a viral or a superadded viral plus bacterial. Symptoms could be fever, cough, and now lower airway will present more of tachypnea with distress and some diffuse or focal lung findings. Next, inflammation could be either allergic or in younger cases, a reflux-like disease. So an allergic mainly comes with maybe a dry cough, a nighttime predominant cough, exertional dyspnea, recurrence of episodes, response to medications, which are mainly a bronchodilators, and could be associated with other atopic disease like your atopic allergic rhinitis or atopic dermatitis. There is significant family history involved in this. In relatively younger kids, there could be either anterograde or retrograde reflux, which is predominantly seen in younger infants, giving wet sounding cough, a kind of a stutter-like sound because of increased secretions, which increases post feeds. There could be vomiting episodes and some secretory sounds. So very grossly, you could differentiate this into classify this into something called inflammatory causes of cough. This we know very well. History is classical, sudden in onset, could be organic or inorganic. But one thing to be noticed that witness choking, a choking episode is absolutely not mandatory. Rather, there have been studies in which there have been less than 50% choking episode witnessed in foreign body aspirations. causes continuous cough, and cough at times even in foreign body could come down or could decrease once this foreign body lodges deep into the airway. So the main problem why the foreign body gives cough is because of irritation of the airway, because of this touching into the airway mucosa. If at all, some foreign bodies like maybe your pin or some a deep small foreign body, once it lodges inside, could also give some reduction in the cough over a period of time, which might lead to something like a retained foreign body. And finally, idiopathic, which could be either psychogenic or hysterical cough, typically seen in adolescent girl, associated with some emotional stress. There is no cough during sleep, and this absolutely doesn't respond with any medication, and the line of management is completely different. So the first approach may be considered as something called as a 4I approach. So differentiating into infection, inflammation, ingestion or aspiration, may predominantly aspiration just to make it I have included ingestion, and finally idiopathic. So with this, let's get to our next approach. Now let's ask some rapid fire questions to ourselves, which we can ask during our OPD to ourselves to make sure what kind of cough are we dealing with. So there are some questions, and how do you interpret it? So first, is cough the predominant symptom? You know that there could be many reasons of cough, many reasons of extrapulmonary reasons of cough. So in this, there are many other extrapulmonary complaints which could come along with cough. But if cough is the predominant problem, you're looking at something like an airway disease. If yes, is it dry or wet? Now, this is again, this cannot be generalized. This we are keeping on a very bird's eye view. A dry cough typically sees as an upper airway. A wet cough, a pneumonic, could be seen in lower respiratory airway disease. Is there any past history of recurrent cough, which suggests something like a reactive airway disease, an allergic kind of cough? Is there any personal or family history of atopy? Again, supports your atopic disease. Is the cough worse at night? So, depending on what time the cough is happening once this child goes off to sleep, you can still classify this into either an upper airway, which is a postnasal drip cough, which can happen soon after lying down, or a bit after, maybe around 2 to 6 a.m., which more suggests something like a reactive airway disease. Onset, whether it is sudden, as is classical in foreign body, or over a few hours, could be again a reactive airway disease. And finally, how is it progressing? If there are recurrent episode, again pointing towards an reactive airway disease, and progressive could be like an infection like pertussis or some lymph node compression over the airway over a period of time like your tuberculosis. Next, we go to sequence of events. Here is what is very important and where we have to focus. Fever followed by cough, cold and cough, very classically suggests as viral infection. A cough and cold followed by fever after 2 days could be a prodrome followed by viral infection. So again, the most common is viral infection in any kind of reason. So that is what I want to focus. A cold and cough without fever could point towards a non-infectious reason like your reactive airway disease. A cough subsiding soon after fever subsides, again a viral infection. Finally, cough for 5 to 7 days after the fever subsides is a viral infection in a known case of reactive airway disease. So moral of the story, the commonest cause of such acute cough is your viral infections, is your upper airway or upper airway infective cause. So we need to cater to that as the properly. Finally, based on the cough sounds, you can interpret as if there's barking cough, like your croup, maybe your upper airway, your glottic, subglottic region inflammation, your whooping cough, typically seen in pertussis, your staccato cough, your continuous cough during your inspiratory phase, as seen in chlamydia, your stridor, mainly involving your upper airway obstruction, is in your epiglottis or retropharyngeal abscess, your wheezing, seen in asthma as well as foreign body. So these are very quick questions that we can either keep in mind or ask ourselves during this OPD to just formulate what type of cough are we dealing with. So initial 4I approach, and finally this quick questions that we can ask ourselves to find the reason for cough. Finally, obviously, honking a bizarre cough as seen in psychogenic, which usually doesn't seem to be like a cough. They make sounds like throat clearing sounds. And once you try to distract them, this cough gradually disappears and especially is absent during the nighttime. Next, this is a very interesting flowchart which I found, in which this acute cough, what they have done is first, as this child presents to cough, let's just focus on the history, not going towards the treatment and management. This cough is less than 3 to 4 weeks. You ask whether there is sputum production, chest pain, shortness of breath, any adventitious sounds heard like wheezing or rales. In an acute cough, the first thing that you rule out is assess for URTI. So whether this child gives history of fatigability, runny nose, sore throat, sneezing, there is some facial pain on facial tenderness, suggesting some kind of sinusitis, which could also be a very important missed cause of cough. On auscultation, usually is normal. On upper airway examination, there could be some pharyngeal erythema, some tonsillar hypertrophy, cobblestoning, which tells you about the chronicity of the cough. Some cervical lymphadenopathy may or may not be present, which points more towards an upper respiratory cause of cough. If these are ruled out, then you go ahead and, if at all, very broadly, the first investigation to rule out whether you're dealing with something is to do an X-ray to see whether there is normal or abnormal. Just to formulate all causes of probable abnormal X-rays, this child coming with an underlying chest pain, shortness of breath, relatively ill appearing, elevated, has fever, tachypneic and tachycardic, has some adventitious sounds, decreased saturation, on X-ray shows infiltrates consolidation. Classically, we are dealing with a pneumonia. Then, in a known case of prolonged cough, having some on and off copious productive phlegm, has crackles, rhonchi, inspiratory wheeze, very classical signs seen on CT as well as X-ray. This could be a past bronchitis, a known case of bronchitis coming with an exacerbation. Finally, pink frothy sputum. There's some dyspnea on exertion, tachypnea, rails, enlarged cardiac. So not only respiratory, but also we have to look beyond respiratory to find something which could be a cardiac reason for cough. So these are all give you a gross in which chest X-ray could be abnormal, which could be found out as a reason for acute cough. Coming to normal, chest X-ray being normal, the child coming with fatigability, shortness of breath, usually ill appearing, some coarse breath sounds that clear with cough, some wheezing present, very classically are dealing with an acute infection again, acute bronchitis with a normal X-ray. A child with dyspnea, some pleuritic chest pain, hemoptysis, tachypnea, tachycardia, low-grade fever, sudden onset increasing of cough, again, relatively in an older child after some maybe strenuous activity, could be very early caught up case of a pulmonary embolism. Again, not very common, but still an acute cause of cough. And finally, the commonest that we see is chest tightness, shortness of breath, sputum production, some rhinorrhea associated other respiratory, other allergic complaints, some wheezing, suggests something like an obstructive airway disease, which is coming with an exacerbation. So more or less, this is a very rough, algorithm in which they have postulated the way how to differentiate cough. Again, they have focused on the URT, which is the commonest cause. These are not so common once it comes to an acute reason, which predominantly are lower airway reason of cough. So what we have learned is an approach towards cough. There are three ways of approaching cough. What wanted to keep it as easy and as simple as possible, not getting into the details. So first is a 4I approach, differentiate between infection, inflammation, ingestion, and idiopathic. Next is the quick questionnaire in which mainly you differentiate between whether it's an infective or an allergic cough. And finally, is this not so common? First, after once you have differentiated your URTI, then looking after your X-ray, whether you're finding something with an abnormal X-ray or a normal X-ray. So this could be as easy as possible. So we learned about physiology of cough, various etiologies of cough, and these three ways of approaching cough. What we are yet to learn, which is most important, as Rawat sir has said, is the rationale for giving cough syrup, because not all cough will respond to your cough syrup, because you need to find out the cause of cough, the pathology and the etiology behind cough, and then make a simplified, a protocol in which you could. Again, cough is not one in which one size fits all. You have to modify it as and when as required for the child, but make a simplified management protocol which would be helpful in both your OPD as well as IPD management. Thank you.
You can stop sharing, Kaustubh.
Yes, sir.
Thank you very much, Kaustubh, for an excellent presentation on acute cough. I think you have presented in a very novel and in a very clear manner in which you have given very, very good insight. Only one question I'll have to ask, the rest we can discuss later on. You have mentioned the role of X-ray chest in acute cough. So I don't think you meant to say that all cases of acute cough they
No.
require an X-ray chest.
No, sir. No.
Just please specify that
Yeah.
in which cases you like to go for X-ray chest, because as you told, most cases they are viral, and in which like after how much time or in what cases probably you will go for an X-ray chest in a child with acute cough.
Right. So, first of all, sir, a cough which is not responding to your first preliminary line of management is number one. That you have thought that it is a URTI, but it is not. So that's why we are keeping URTI separate. URTI doesn't mandate an X-ray chest. So once you have given your basic line of management, maybe you have given your medications, your cough suppressants or whatever, as will be discussed ahead, and this child is not responding towards your basic line of management, maybe you have given a week or two of your basic medication. And further, when you think that on your general examination, you have some specific pointers which you think that will give you some specific findings on X-ray, these are the chances when we actually decide. So absolutely no, as you rightly said, not all acute cough require X-ray chest, rather very less acute cough require X-ray chest, and only for those in which you are in doubt or your medications are not working.
So I think the very very important learning which we have got from your talk is that if you are trying to approach a child with acute cough, please make a specific diagnosis.
Right.
A viral respiratory infection doesn't mean anything. A cough with viral URT or LRT doesn't mean anything. Specific diagnosis, whether you are dealing with acute viral rhinosinusitis, you're dealing with a viral bronchitis, you are dealing with a viral pneumonia, or you are whatever. If you put the specific diagnosis of a child with cough and viral infection, then your prescription would be rational, your treatment would be pinpointed. And as Dr. Kostab has told that in case if you don't find a cause and you have treated the child for say about 7-10 days and you think that something else is going to come up, ordering investigation should depend upon what you think in your mind. It should not be a blanket trying to give all the list of investigation like go from CBC to FHS and CT scan. So what is your DD specific as Dr. Kostab has told you that beautiful algorithm which he has told us. Try to pinpoint what exactly you are thinking, and then you can tailor your investigation depending upon what is that particular case. So, Kaustu, thank you very much. We
Thanks.
will again come back to you. So we go for the next talk, and for the next talk we have got Dr. Ankit Parak. He is a senior pediatric pulmonologist from Delhi. He is at BLK Max in Delhi, and he's a very experienced pediatric pulmonologist and a very astute clinician and a great speaker, and he would be telling us on OTC cough mixture. And I have divided this talk into two parts, part one and part two. He'll take part one where he'll discuss three OTC component, followed by we'll have Dr. Rashmin Das who will discuss the other three components. So he'll be taking us through what is the pharmacology, what are the indication, contraindication, and whether we should use these particular drugs or not. So I'll request Dr. Ankit to start his presentation, please.
ठीक है. Good evening, everyone. Kindly allow me to share.
Sir, you can share.
Yeah. Okay, fine. Okay, so I hope my slides are visible.
Yes, sir, they are visible clearly.
Okay, so a very good evening to everyone. So in the next 20 odd minutes, I'll try and focus upon cough syrups in children, and the role which has been cut out for me is to briefly discuss on the three components. So one is oral antihistamines, oral decongestants, and oral antitussive agents, right? So I'll briefly talk about these three agents. So the aim is to discuss the safety. Well, that is paramount because we all understand that there was an issue in between, and safety of whatever you are giving is something which is paramount. So what data do we have, what approvals do we have is important to understand, and does it actually or really help a particular child where you are actually trying to give any of the cough mixtures. So we'll talk about these three components in the next few minutes. Now we understand that cough cold combinations, they have been used for the past many years, and at that era there was a much lower level of evidence that was required, and there was no comprehensive review system which was there, and these are drugs which were grandfathered to us. When we were trainees and when we were senior residents, we gradually learned that this cough mixture can be used, and there was no real questioning about the safety and the efficacy data. And a lot of discussion, a lot of data which appears is actually extrapolated from adult studies. There are very few studies in children. And it also applies to doses because as we go through, you will realize that a lot of adverse effects which happens with any of these cough mixtures are dose dependent, right? A lot of side effects occur when the doses are exceeded accidentally or by parents or somehow, right? So what is the correct dose is again a big question which we actually need to answer, and do we actually have data on this? And as we understand, the evidence for efficacy is actually not really available for most of the drugs, especially when you are dealing with combinations, right? And the safety of these combinations have not been tested. So even if you have individual components which are tested, the safety of these combinations are not really tested. And uh, there are different brands who have different doses, right? So there can be a brand which contains chlorpheniramine as 1 milligram, some can have 2 milligram, and so on, right? So the safety and the efficacy for all these doses is something which is not very well known. And then to add to the problem, you have a lot of combinations which contains, bronchodilators. There are combinations which contains theophylline. There are combinations which contains um, analgesics or sometimes paracetamol. So it is a bit difficult in this situation to draw out data. Okay, now having said that, uh, uh, well, most of people understand, right? We all as respiratory physicians, we all as pediatricians, general physicians, everyone understands that, if you ask anyone, everyone would say, yes, we understand that, cough mixtures sometimes are not very helpful and they can have some side effects. But why are they still used? So they're still used because one, you need to give something to the family, right? When they come to you for a consultation, you do need to give something to the family. Uh, and one of the reasons is to justify your consultation. So that has been a big plea by most of the people who practice medicine, right? uh, and there is a lot of anxiety from parents. It is a discomforting illness. uh, the child is coughing badly, and someone saying that you don't need to treat it is not something which has been taught to the family from day one. They have been in a habit of getting something, right? Their own comfort. They want to, they're tired, the child has not slept, they haven't slept. There's a feeling of helplessness. The child is coughing, the child is having so much of courage, the child is not sleeping, the child is vomiting, and you're not doing anything. And then the parents fear as well, right? So these are some general reasons which may not be scientific, right? But that is the hardcore reality. Why a lot of pediatricians, if you ask, they are writing cough syrups, even if people understand that there can be issues, there can be it can be a lack of efficacy, and it can be some adverse effects, right? There is a lot of self treatment which goes on in India. A lot of people would say, "Wow, your eyes are self limiting, my child gets often, the parents are busy, they don't want to sit in the pediatrician's clinic." And what you have advised the last time, they would carry on the prescription, or they would ask someone else, they would ask the chemist, and do that. And why am I saying this is because I'll show you data which suggests that when non-prescription drugs are used, then the risk of adverse effects are many folds. There is mortality data as well, and I'll show you the data which has been published. So the non-prescription drugs is a serious issue. Uh, so it is not just the pediatrician who is writing the drug. Most side effects appear when it is a non-prescription drug used in wrong doses, right? So that's a big problem when they are self-treating, right? And that points need to be borne in mind, and that is the reason why I'm talking about this. Right. Uh, well, these are the coughs, cough mixtures, different combinations which are available on your screen. We don't need to go into the details, but what I'm just trying to say is that uh, so many irrational combinations you would see day in and day out, and obviously you will never have any efficacy data because they are non-scientific, and hence doing a trial on this is impossible. Right. And as I said previously as well, the problem is increasing because a lot of them will have some form of bronchodilators, terbutaline or salbutamol or levosalbutamol, and then some theophylline and so on. Right. Now, so we get down to the point here that what do we have basically in a cough mixture? So you have antihistamines, usually first generation, occasionally second generations. Also, the most commonly being used are chlorpheniramine, CPM, diphenhydramine, which is your commonly Benadryls, phenyramine, promethazine, which has been, commonly used as Finargan, and you have hydroxyzine as well, which we commonly use. Then antitussives, the most commonly used is dextromethorphan, but people occasionally do use codeine, noscapine, folcodeine, and levodopa, right? That's something which is coming up, especially after all these cases happened. Then you have decongestants like phenylephrine, pseudoephedrine, oxymetazoline, xylometazoline, and phenylpropanolamine, which actually had an FDA black box warning. The mucolytics and the rest Dr. Rashmi will deal in the next talk. And then you have new generation cough syrups, which is montelukast levocetirizine, which was never meant to be a cough syrup, but it is really used as a cough syrup these days. Uh, and that is something which we should refrain from. So if other thing is banned, we are going to use this. No, that's not the correct thing. Well, you have a cough reflex, which starts with the stimulus. So you have an afferent limb. Then you have the centers in the medulla oblongata from the tractus solitarius. And then you have an efferent limb, uh, which leads to laryngeal and respiratory muscles, which leads to a cough. Now, why am I talking about this is because there are few drugs which act on the cough center in the medulla oblongata, that is your central antitussives, namely codeine, folcodeine, noscapine, and dextromethorphan. So these are drugs which act on the centrally, but there are drugs which acts on the peripheral system, okay, and the type C fibers, and that is your levodopa, and that is what they are trying to talk about these days, right? So there are a lot of afferent fibers from the nose, from the pharynx, larynx, from the trachea and the bronchi. It goes through the medulla oblongata, and then you have afferents which are present into the diaphragm and into the rest of the inspiratory muscles and which are there. Now, there are two clinical questions which we are trying to answer. The first is, in children with acute cough, do cough syrups alter the outcome in terms of symptom relief, uh, the frequency or the severity of symptoms? Does it improve the quality of life? Okay, and you have to compare with the placebo, because any study which deals with self-limiting infection, the placebo arm is also very strong, meaning thereby that a lot of self-resolution is happening. So is it actually the disease which is improving on its own, and the credit goes to the cough syrup or the credit goes to the doctor, right? Or is it actually the treatment which is efficacious, right? So we have to look at the placebo arm as well, right? Uh, and then we talk about the clinical safety, right? So single drug combination severity, right? Are these side effects minor, or they can be life threatening? They can lead to mortality. Uh, in recommended doses, so that's one, but also in unintentional overdosing, right? That's important to understand because a lot of data has come up on this. Okay, so let's start with antitussive. So we have, as we've talked about, they are centrally acting, which inhibits the cough reflex by suppressing the cough center in the medulla. The narcotic and the non-narcotics. So codeine is being the narcotic antitussive, which has been used widely, and then you have non-narcotic, and the most importantly that we use often is dextromethorphan. And then you have peripherally acting, and the most commonly being advocated is levodopa, and we'll try and focus on these two. So just briefly, codeine suppresses the cough centers. It increases the threshold of cough, but it can lead to some CNS depression, constipation, and can have some addiction component as well. This is a Cochrane review, which was published. So they were dealing with codeine versus placebo in children. So this comes from the Brisbane group led by Anne Chang. So it highlighted that there are not really any good randomized control trials which are evaluating codeine-based medicine in the treatment of childhood cough, right? And because there is a potential of adverse effects of respiratory depression and opioid toxicity, uh, the National Therapeutic Regulatory Authorities contraindicates the use of codeine below 12 years of age. And hence, it was recommended that in clinical practice, we adhere to the clinical practice guidelines and refrain from using codeine or its derivative to treat cough in children. So, again, no efficacy, no real data which was there to support the use. And in addition, there are side effects which appear to be significant. Uh, Likewise, there have been reports like this. So, this paper from the American Academy of Pediatrics, and it was an old paper, but it was reiterated in April 2025. So, what they say is that codeine is a prodrug, um, and it gets metabolized in the liver. Now, the problem is that there's a lot of genetic variability in metabolizing codeine. So, when it changes into the active drug, so is it a slow change? Is it a fast change, right? So there can be slow metabolizers, but there's a population of children who are ultra rapid metabolizer. Uh, and that leads to a different concentration of codeine in the body. It has also been documented that in children who have suspected sleep apnea, the danger can be much more. So various organizations started saying, including the WHO, the US FDA, and the EMA, that is the European Medical Agencies, they actually sent a stern warning regarding the occurrence of adverse effects of codeine in children. And hence it was contraindicated for use either as an analgesic or as an antitussive agent, right? Uh, so most agencies saying that it is better to avoid codeine in children. Now there are other antitussives which have been used infrequently, like codeine, similar action to codeine, but not having any analgesic or addictive properties or a longer duration of action, but seems to be similar to the group. And then noscapine, um, which is again a potent antitussive, but obviously you again don't have data, real data to support the use. Okay, now the next antitussive is dextromethorphan, right? So dextromethorphan is something which has been used, commonly in children. So again, it is a centrally acting antitussive agent. It is thought to be an NMDA antagonist, which are there in the medulla oblongata. Again, no analgesic property, and it doesn't lead to constipation and addiction, and doesn't affect the mucociliary function. And that is the reason why it has come up in a big way in most of the cough mixtures, right? The dosing, which is, postulated, is something like 0.5 milligram per kg up to 30 milligram 3 or 4 times a day. This has been something which is advocated. Most the adverse effects appear to be like nausea and GI discomfort in the usual doses. But what we also need to know that in higher doses, it can lead to delusions, hallucinations, dizziness, and nystagmus. And there's a lot of data which has come up on dextromethorphan adverse effects as well. So this is a data which was published on the adverse effects associated with pediatric exposures to dextromethorphan. And this is from the US FDA sources. So they they took the OTC medicines and they were looking at the OTC medicines and they sought to characterize adverse effects associated with dextromethorphan in children under the age of 12. So again, a retrospective data. And so what they found was that, the adverse effects which were there, only 3% were following an ingestion of a therapeutic dose, right? And 78% of the adverse effects followed an overdose, okay? Around 70% involved unsupervised self-administration, okay? And almost 60% occurred in children who are less than 4 years of age, right? So in this study, they did not found any deaths or pathological dysarrhythmias, but they did found CNS problems like ataxia, autonomic symptoms, tachycardia, flushing, urticaria, and dystonias, right? Uh, so we need to understand that, even if this data appears to be innocuous, saying that, only 3% had problems with therapeutic doses, we still would understand uh, that if doses are crossed in the US or in Canada, then the doses are very well crossed in India as well. Well, there's a lot of dosing error which happens, and there's a lot of self-treatment which happens. A lot of treatment occurs from the pharmacy, right? So it is highly unlikely. It is highly unlikely that India is not facing this problem uh, with the dosing, right? Now let's look at this data. So if that data doesn't scare us, okay, then this data would, right? So this is a data which is a fatality data, okay, associated with over-the-counter non-prescription cough syrups, right? So no one advised those cough syrups because they were available on the OTC list. Uh, uh, this happens, right? So they were looking at fatalities, and what they looked at is that these fatalities, they looked at the fatality data and they were trying to analyze that was this child given a cough syrup in the last 10 days or 2 weeks. Now, in this data, they found approximately 190 cases, which out of which 118 cases were judged to be possibly or definitely related to a cough cold ingredient. 118 of these cases involved a non-prescription drug, uh, and these are mortalities, right? And several contributing factors were identified: age younger than 2 years, use of medication for sedation, use in a daycare setting. Uh, Using two medicines with the same ingredient, right? It's quite common to use two cough syrups in India. It's not uncommon. Prescription by doctors is one, and giving two cough syrups together by parents is something which is not uncommon. Saying that my child was not improving with this drug, so I thought I'll give this and this. Okay, so that is something which can be fatal. This is something which we need to remember. Coming to the newer one, which is levodopa, so it is thought to inhibit the peripheral airway sensory fibers, the C fibers, reducing the afferent impulses to the cough centers without any CNS depression, and that is the reason why it has come up in the market, saying that it is something which is safer to use as compared to dextromethorphan, right? So not much data on levodopa, and obviously anyone who talks about this would talk about this meta-analysis which was published somewhere in 2015, which included 4 pediatric trials. Now the problem is that uh, you need to show the efficacy in a placebo arm in a significant number of patients, uh, and show that at least the cough has reduced by 15% or 18% over and above the placebo arm. That is what you need to demonstrate, right? The problem is that the studies that were included in this, okay, were mainly compared to dextromethorphan or codeine and only one study was there, which was placebo study. And moreover, in this study, the number of children were limited. And again, as you see, the indication was something like an asthmatic cough. So what I'm trying to say is that we don't have very robust data, even on levothyroxine, even if it might appear a bit safer, or even if you read the conclusions of the meta-analysis, it might say that it is very good. So again, this is the data from the meta-analysis, again from the pediatric and the adult studies, which shows levothyroxine is better. But again, this data is not very robust for us to be really being convinced that levothyroxine can be used freely as an antitussive, and we start recommending it left and right. We need to be really cautious about our approach, because what the IAPNRC would say would percolate down the system. Then there are reports of levothyroxine-induced anaphylaxis. So this is a case series in review that was published from Korean centers, where they had done even oral challenges to prove that it was only the levothyroxine which actually led to anaphylaxis. And this is something which we need to remember. Right. And then let's change to antihistamines. So it is usually added to antitussives and expectorant formulations. Uh, so how does the antitussive action happen with an antihistamine, and why do you need to add it? Well, the antitussive action is not possibly related directly to the H1 receptor blockade. Uh, One mechanism is the lipophilic nature of the first generation antihistamine, which are CNS penetrating and they are sedating. And there are other mechanisms like inhibition of the TRPV1 receptor and the anticholinergic effects. But the relief in cough, it lacks selectivity for the cough centers. It can dry up the secretions because of the anticholinergic effects. These are the list of drugs which are commonly used. We all know about it. So diphenhydramine, chlorpheniramine, hydroxyzine, and promethazine. These are the favorites. And then you have second generation antihistamine, which are usually not there in the cough cold combinations. And because they are non-sedating, they possibly do not lead to that effect that we are looking for. They are principally either used either for urticarias, or they are used for treatment of allergic rhinitis. And they're not basically meant to be used for viral upper respiratory infection, which are non-IgE mediated or inflammatory diseases. Uh, Now, you might feel that I'm a pessimist, and I'm telling you everything negative in this world. I understand that. But finally, I have to show you what is there in literature. Uh, so this is a list of adverse effects which have been shown to be there with H1 antihistamines. Um, and The first is the CNS side effects. So it can lead to drowsiness, fatigue, somnolence, dizziness, impairment of cognitive function, memory, psychomotor performance, headaches, dystonia, dyskinesia, agitation, confusion, hallucination. So long list of CNS side effects which have been documented by H1 antihistamines. The other, which you all need to remember, is that it can lead to cardiac side effects, and they are known to induce arrhythmias. Right, the mechanism is not very clear how it happens, but it is well documented that H1 antihistamines can lead to arrhythmias, and it has been shown with drugs like cyproheptadine, diphenhydramine, doxepin, hydroxyzine, promethazine, and others. So it leads to sinus tachycardias, reflex tachycardias, supraventricular arrhythmias, prolongation of QTC intervals, and ventricular arrhythmias as well. So it's not something which is innocuous. And then obviously, as I'm talking about, as I've shown you data, there's a problem of toxicity, right? So this toxicity happens day in and day out, and then all your side effects can be exacerbated and can lead to fatalities as well. Uh, Then there's a lot of data which has now been published on seizures in children. So people have looked at, this seizures happened, so this febrile seizure happened, this seizure happened, and they went back in the last 2 weeks and saw what medicines were used. And then they tried to correlate the cough cold medicines with seizures. And if you look at this analysis, then they said that the stratified subgroup analysis showed consistent results, particularly in children between 6 months and 24 months of age, who were prescribed first generation antihistamine having a higher risk than children aged 25 months to 6 years. Right. So again, that's a problem which need to be borne in mind. So this is the data again, the Korean data which was published and which was showing that there is a definite risk of adverse effects leading to cardiac arrhythmias and ischemic heart diseases in children, especially between 6 months and 2 years of age. So this was a first generation antihistamine winter warning by the Australasian government, saying that the flu season and the winter season is there, and the consumers and the healthcare professionals, they are reminded that first generation antihistamines, including OTC drugs, should not be used for treatment of cough, cold, and flu in children under 6 years of age. And first generation antihistamines should not be given in children under 2 years of age for any indication, right? So 2 years of age for any indication. Then you have decongestants like pseudoephedrine, phenylephrine, and phenylpropanololamine, and they have been a part of a lot of cold medicine. So they contain the usual combinations would be CPM phenylephrines, or triprolidine used along with phenylephrines. So this is a very common combination which is still rampantly used, and a lot of major brands have this. So again, a pessimist view, please don't take that seriously. But a lot of data again, would discourage you. So a PPA phenylpropanololamine was asked to be removed by the US FDA and Canada because it led to increased risk of hemorrhagic stroke. So Health Canada said that don't use CCMs in cough syrup formulations less than 6 years of age, and caution in more than 6 years of age. Absolutely no in less than 2 years of age. And this has come up in 2024, November 7, by the FDA, and they have started saying that oral phenylephrine is not something which is effective in clinical practice. They said they have reviewed all the data. They released a monograph saying that oral phenylephrine is widely used as an oral nasal decongestant as an active ingredient in the OTC products. But they have given a monograph saying that these should be taken out from the US market. So I understand that it hasn't happened even in the US as of now completely, but this is something which has come up from the US FDA after reviewing all the data which they had. So there are two meta-analyses which have been published, Cochrane meta-analysis on cough cold medicines in children. So this is the first one in 2014. Which was published, and they said that they reviewed all data and they found that they're not no more effective than placebo. So that's one thing which needs to be remembered. And in addition, there's a wide range across studies with higher number of adverse effects in participants taking antihistamines and dextromethorphan. So that's another problem which we are dealing with. So what they have said is that the availability, dosing, the duration of use of over-the-counter cough medicines, they vary significantly in different countries. And there is no good evidence for or against the effectiveness of OTC medicines in acute cough. And this should be taken into account when considering antihistamines or centrally acting antitussive agents uh, that are known to have the potential to cause a serious harm. And this Cochrane meta-analysis came back in 2022, where they looked at 30 studies. There were placebo controlled. There was an active arm in few of these studies. There were adult studies. few of these studies were children, so nine childhood studies as well. So again, the author's conclusions remained almost the same, that there's a lack of data on effectiveness. Okay, the effect on the individual symptoms is probably too small to be clinically relevant, right? Uh, Saying thereby that you might feel, I've used it for last 15 years and I feel, after giving this cough syrup, the child improves. But that is something which is not scientific. That is not something which has been proven that it is actually more beneficial than placebo. The current evidence suggests that antihistamine analgesic decongestant combinations, they can have some benefits in adults and older children, but not in younger children, absolutely. And they need to be weighed against the serious risk of adverse effects. Um, and we do not have any evidence of effectiveness in young children. So I would conclude with this slide that the relief with cough syrup, you know, was not only comparable to a placebo, uh, but the problem is, even if you're looking at a placebo and saying that I'm using a cough syrup, at least it is a placebo, or at least I've done my consultation. I've given something for the parents to look at. I had to prescribe something. The problem is the argument, even the argument uh, against the use of these cough syrups as placebo uh, is that the frequency and the severity of adverse effects reported with most of the pharmacological preparations uh, tell us that even using it as a placebo is not something which is clinically advisable. The side effects can range from insignificant, transient to serious adverse effects and even deaths. Uh, Even if you might come up and say that I haven't seen anything in the last 10-15 years, but what amount of monitoring do happen in India? Right? If they happen in Canada, if they happen in US, you have US FDA who is willing to publish their data saying that this is something which has happened in US. It is not very easy to publish a negative data saying that, telling public that use of cough cold combinations can lead to serious adverse effects. So I think we need to take it seriously. I understand that saying everything no 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 is not something which people would like to hear. That's the harsh reality, and we will later in the panel discussion talk about that. We are saying all no's, but what is the yes? And how do you deal with these conditions in clinical practice? So thank you very much. I'll stop here and I'll hand over back to Dr. Rao.
Thank you, Ankit sir, for an excellent compendium on antihistamine, antidepressant, anticoagulant. I think you have highlighted very, very clearly their specific pharmacological actions, their side effects, the worldwide reports of toxicities, even fatalities, and a very clear guideline that there is no role of these medication in routine management of respiratory infection in children. They're definitely not to be used below 6 years. After 6 years, really, we don't have any guideline. Government of India is under the process of making some guidelines for the use of these cough mixtures. I don't know when it will come, but till now, I think whatever that data you have presented, it seems to be very promising, and I think it is giving a very clear message that these drugs are not to be used. Whatever may be the parental pressure or peer pressure or farm pressure, whatever pressure you may say, but I think even as a you are doing a very important statement that even if you are using as a placebo, there is a risk of side effect, toxicity, and then definitely things can go bad because of self administration or sometimes giving it accidentally overdose. So I think thank you very much. We'll again come back to you after panel discussion. In case if there are any questions, we'll again come back to you. So after that, we'll have part two of this discussion where we'll be discussing mucolytics and expectorants, and to take to this two particular important group of drugs will be Dr. Rashmi Das. He is a professor from AIMS Bhubaneswar, a very avid researcher. He had got huge number of publication to his credit, an excellent speaker, and we'll listen to him what is the exact position of these two drugs, basically mucolytics and expectorant, because they are the part of almost all OTC cough mixture. And again, we'll have some clear view regarding these two drugs. Rashmi, over to Rashmi, please. Thank you.
So thank you so much, sir. So I'll be dealing with, as sir was telling, the second part of OTC cough mixers, and that will be regarding expectorant and mucolytics. I'll slightly like to tweak the title. The title is rationale of their use. So it should be, is it rational to use them? So that should be the tweak kind of to the title. So what I'm going to cover today, so I'll be telling you the definitions of this expectorant and mucolytics. And I'll be telling you what is the pathogenesis, like how this mucus clearance happens and what are the factors that affect it actually. But better understanding the mechanism of the drugs. And most of the acute cough are viral in nature. So let us try to understand how the mucus is affected in different types of viral infections. Okay, so then I'll take you to the proper topic of today, and I'll be telling you the classification of different drugs, their mechanism of action, and what the evidence shows, and finally, what we should do or what is the take-home message. So coming to the definitions. So expectorant are the drugs that lead to increased bronchial mucus production, make secretions easier to remove by cough or ciliary transport. Whereas mucolytics, so these are the drugs, they aim to decrease the viscosity of the bronchial secretions, act to make secretions easier to clear through coughing. So they are distinctly different, but there is a common overlap between them. So that's why these group of drugs are commonly classified under a broad heading known as mucoactive drugs. So there is some degree of overlap between these drugs, but this is the definition what defines them. So let us try to understand airway mucus clearance, because that will be very vital to understand how these drugs act and whether we should use these drugs or not. Okay. So this airway mucus clearance, it is a continuous process. So that happens from the distal to proximal airways. Okay, so if you see in this picture, at the alveolar level, at the small air level, there is hardly any mucus production. Okay, because here the airway anatomy is a bit different. So there are cuboidal cells, so there is no mucus production. So how the airway patterns is maintained here is by the surfactant production. And if you go more distally to the bronchioles, so again, there is lack of mucus production, but luckily there are few Clara cells. Okay, they produce small amount of mucus, and as you can see in this picture, there is a thin mucus there. So here there is mucin production, but the amount is very, very less. As we move more distally to the larger airways, so here you see, so there are large number of submucosal glands, and here actually large amount of mucus production happens, and these mucus are added by the ones that has moved from the distal part. Okay, so larger airways contain mucus, and this mucus, what will happen, once they will ascend to the trachea, they will propel to the vocal cords by the ciliated epithelium that is particularly present in the posterior aspect of the larynx. And once it crosses the larynx, it will come to the pharynx and it will be swallowed. And approximately 30 ml of airway mucus is cleared by the GI tract. Okay. So what are the factors that affect this mucus clearance? So if there is dehydration, okay, so it will affect, it will decrease. So hydration is a very important factor. In fact, the major factor that decides the mucus clearance. The second one is the rate of ciliary beating. So if there is a problem in the ciliary beating, again, mucus infection will happen. That classically happens in different chronic diseases like CF. Third is cough clearance. So once, as I told, the mucus comes to the distal part, so what will happen? So cough will happen. So vocal cord, so they will close and they will create the pressure. So there is no ciliated epithelium over the vocal cord. So, but it will be a part of this cough reflex and try to clear the coughs. So out of these three, if you see, hydration is the most important factor. And studies have shown that, in fact, it is the dehydration that affect both ciliary beating and cough clearance, and it causes more problem in mucus clearance compared to your isolated ciliary beating or cough reflex. And in bronchitis and tracheitis or tracheobronchitis, that's why the mucus production is high, because as we discussed, the majority of the gland, they are they are in the larger airways. So acute cough most commonly caused by your viruses. So let us try to understand what virus does to the respiratory tract. So whenever there is viral infection, it will cause infection of the epithelial cells of the nasal passage. It will cause sore throat and sneezing. There will be inflammation, blood vessel dilatation, blood vessel permeability. So that will cause edema, obstruction of the nasal passage, and there will be exudation of serum also. And at the same time, it will irritate the airway receptor. It will cause cholinergic stimulation that will cause mucus production. Okay. So again, there is exudation along with mucus production. So that will cause rhinorrhea. And there is additional bronchoconstriction or the bronchospasm. So this mucus along with bronchospasm, so what it will cause? It will produce the cough, because that has to come out. Otherwise, there will be a problem. So probably this was the reason behind the invention of mucolytics and the OTC mixtures that contain this mucolytic or expectorant with bronchodilators, keeping in mind how the viruses affect the respiratory tract. But please remember, any persistence of post-viral cough, because the viral cough, acute viral cough, that will disappear by 7 days. But if it is persisting more than 7 days without improving, you have to think of underlying airway reactivity or underlying allergy. Okay, the child may have some allergy complaint, like maybe a kind of bronchial asthma, or he has a allergy that is causing wheezing, something like that, or any other disease. Because after the end of the week, the viral cough classically tries to improve. And in bronchiolitis, as I was showing in the earlier picture, mucus is less, because in bronchioles and alveoli, hardly there are any mucus producing cells. So here mucus production is less, but the obstruction or the patchy collapse that happens in bronchiolitis is because of the cell debris, fibrin plaques, and surfactant dysfunction. So this is very important to understand in order to decide whether we should prescribe expectorant or mucolytic in viral respiratory infections or acute cough. So does all virus affect equally mucus production, mucus affection? The answer is no. So let us try to see what each virus causes to the respiratory tract. So if you see influenza virus, they cause increased mucus production, increased viscosity, and they cause bronchial and tracheal mucosa swelling. RSV, it increases mucus production, viscosity, but it also causes luminal obstruction by producing thick plaques which contain mucus, fibrin stand plus cell debris. Parainfluenza virus, it increases only mucus production. Rhinovirus increases mucus production, cell debris, increase neutrophil in the sputum. Human metapneumovirus acts very similarly to that of RSV, but severity is a bit less. It increases mucus production, and there is also luminal obstruction. SARS-CoV, it causes mucopurulent secretion, mucus retention, and the mucus is actually very thick, and it is gray-white exudate. So if you see different viruses, they affect differently the mucus. So by going this, you cannot tell a single drug that is going to be effective in a particular virus infection. And when the child comes to you, you do not know which virus is actually affecting or which virus is the culprit. So if you give a single drug, it may not act or it may be counterproductive, because here they affect the mucus differently. So now let us come into today's topic, that is the expectorant and mucolytic, and this is the classification. So the mnemonics are, for expectorant, it is AMGHI, ammonium chloride, mannitol, guanfacine, hypertonic saline, and isotonic saline. Mucolyte, the mnemonic is ABCD, N-acetylcysteine, ambroxol, bromoxane, carbocisteine, and Dornase alpha. Okay, so this is the broad classification. But already I have told there is some degree of overlap in their mechanism of action. So let us discuss one by one. So coming to guanfacine. How it acts? It reflexively stimulates the gastric mucosa, activates vagal pathway, leads to increased tracheobronchial secretion. In fact, all expectorant or mucolytic, paradoxically, they will cause bronchoria. So they will thin the secretion, but at the same time, they will increase it for better clearance. It causes enhanced mucosal clearance, doesn't suppress cough reflex. So cough reflex is intact here. So it is commonly combined with different type of mixtures. I'm not going to detail. That is already available in the market. And caution is dry cough because it will make it more productive. And if you're using in cough more than 7 days, it is problematic. Okay, it may be counterproductive. So these are the studies that were conducted regarding the role of guaifenesin in acute cough. All trials were in adults, and they were very small trials. And there was a conflicting kind of evidence. So some were telling that it is helpful, some were telling that it is not helpful. And but all trials unanimously found that hydration enhances its effect. So when the hydration is affected, the drug is not acting well. So that was their observation. And this was the Cochrane review that was published regarding the effect of this guaifenesin. And all these 3 adult trials were pooled, and only 304 subjects were there, and the result was conflicting. But there was no studies in children, so we don't know whether guaifenesin actually helps children with cough or not. Then coming to ambroxol, so it is active metabolite of bromhexin. Again, it increases serous secretion like any other mucolytic expectorant. It reduces mucous viscosity, enhances mucosal clearance, stimulates surfactant production. So that is a very interesting action of ambroxol. That's why in some of the trials it was tried in patients with bronchiolitis, because in bronchiolitis there is some degree of surfactant dysfunction, and it has been also been tried in ARDS because there is surfactant dysfunction. And in addition, it has many other effects, as you can see in this picture. It is also a combination of many OTC cough mixtures, and same caution as your guaifenesin. Then coming to the evidence, as you can see, so all trials were very old, almost before 1990. And some trials, they have compared ambroxolol versus placebo, and some compared with active drugs like N-acetylcysteine. The duration of uses varied from 2 days to almost 10 days. And if you see the domains, there is no uniform domain. Actually, a mixture of diseases has been included in the studies, which is very unusual actually. When you are trying a drug, you should try for a single disease. You cannot mix up the disease because their mechanism or pathogens is different. But they have done that. But interestingly, all of them have found that it helps. And in fact, ambroxol acts better than N-acetylcysteine and carbamazepine. But please mind, all these are open label trials. So there is a high risk of bias. Sample sizes were small, diverse conditions were studied, and all these trials were conducted before this GCP, that is the Good Clinical Practice, came into place, that is before 1997. So GCP is very, very important in conducting any kind of trial and drawing the conclusion. No trial should be conducted without the GCP, and the person who is conducting the trial, the investigator, has to be trained in GCP. That is mandatory. So if you are not practicing GCP, that means it is up to you to decide, and you can manipulate the things also. But if you are going by the ICS GCP, that means you are following the right way to conduct a clinical trial. But all these trials were conducted, and no trials were conducted after 1997, which is very, very important regarding the evidence. Again, all these studies have found that hydration enhances the drug effect. Coming to bromhexin, it is a prodrug of ambroxol. Again, increases secretion from the submucous glands. It reduces mucosal viscosity, enhances mucociliary clearance, makes cough more effective. That is one interesting part of bromhexin. So it facilitates cough actually. Again, it is found in different cough mixtures, and same caution like that of others. And interesting is peptic ulcer disease, because it has been found that it will aggravate the peptic ulcer disease. So what is the evidence in acute cough? There was no trial. One trial that was conducted, it included children with acute sinusitis. So acute sinusitis causing acute cough, and the result was that there was a decreased nasal congestion. Beside this trial, no other trial has been conducted, and majority study that has been published are observation studies. Okay, again, diverse clinical conditions, but consistently, very interestingly, all these observation study have found that bromhexin improves clinical parameter in children with acute cough. Again, they have found that hydration enhances the drug effect. So this was a Cochrane review that was published regarding the effect of bromhexin, and only one adult trial, as I showed you, that was published. And interestingly, this adult study found that there was a 50% reduction in acute cough, no adverse event was noted, and there was no study in children. So coming to hypertonic saline, there are different preparations that are available. It is a very interesting drug, very commonly used in chronic suppurative lung disease like CA, PCD. Different preparations are available, 3%, 5%, 7%. Its mechanism of action involves osmotic effect, that it decreases viscosity, hydration of airway surface liquid. This airway surface liquid is very interesting thing, and it is very important in chronic suppurative lung disease like CF and PCD, in which the ASL is affected. Once the ASL is affected, so bacteria will colonize. So that's why hypertonic saline is very effective in all these conditions, because it is only you can tell the expectorant that affect the ASL, which is a very positive thing. It enhances mucociliary clearance, facilitates cough clearance. It actually facilitates cough, decrease airway edema, which is another added point, because in some viral infection we discussed like influenza, there will be airway edema, also in other viral diseases. So it might help in those conditions. And in addition, it has anti-inflammatory effect because it decreases the local inflammatory markers. It inhibits them. Additional point, only nebulized form. It is non-sedating, non-systemic, because there is no systemic preparation available. But mind it, it can cause or aggravate bronchospasm. 3% saline, the reports are rare actually, this bronchospasm, but it may happen with higher strength. That's why many people, they use bronchodilator like aspirin, like salbutamol or any kind of bronchodilator before giving the 3% this hypotonic saline. So that is the reason why, because it might aggravate bronchospasm. So what is the evidence in acute cough? No trials in acute cough except acute bronchiolitis in children, and no trials in adults with acute cough also. So we do not have any evidence or any published study regarding hypertonic saline in acute cough. That is the post-viral. So bronchiolitis is a very common condition in infants. It is a common cause of cough also, and it is a viral disease. So let us try to see what the Cochrane evidence shows. Okay, so large number of trials has been conducted, almost 34 trials, out of which 3% saline was included in 20 trials, and 6 trials included 5%, 7% saline, and almost 5,200 infants were included. So such a big kind of data we have. And the result was this hypertonic saline decreases risk of hospitalization by 13% and decreases hospital stay by 10 hours. But it has uncertain effect on cough or wheezing. Okay. Regarding safety, when it was administered alone, there was a report of worsening cough, bronchospasm, agitation, desaturation, diarrhea, and vomiting, and bradycardia. But they were mild and resolved spontaneously. So that's why it is preferred, not mandatory, to pre-medicate with salbutamol, okay, to safeguard against these side effects. Then N-acetylcysteine, it is another common drug, again used in chronic suppurative lung disease and other muco kind of conditions producing a high amount of mucus. Different preparations are available. And this drug can be used as oral, IM, or nebulized form. It regulates mucus production. It enhances mucociliary clearance. It facilitates cough clearance. It also has anti-inflammatory effect like your hypertonic saline. And in addition, it has antioxidant effect. Caution can cause or aggravate bronchospasm, increase bronchial secretion, and respiratory distress. And this nebulized form or inhaled form, though it attains high concentration in the airway, but the effect is short-lasting. So that's why commonly in adults, I have seen they usually use the oral preparation. So in different OTs combination, it comes as oral preparation because the systemic absorption will produce a long-lasting effect, though the concentration may be less. Actually. So let us see what the evidence shows. Again, all the trials were published before 1997. The duration varied. That varied from 3 days to 20 days, as you can see in the study design. And some studies compared NAC versus placebo, some compared with the standard treatment, some compared with bromoxin. And another drug that is Sobrerol, I could not find it in Indian context, whether it is available or not. Again, diverse domains were studied. Like a single trial included children with different conditions, which is very unusual. And in fact, one trial, the third trial, you can see it included children with TB also. I don't know why. So, but all the trials consistently show that it improves symptom, it decreases fever because of anti-inflammatory effect, it may improve dyspnea. And but again, interesting, all studies were conducted before 1997, before this GCP was implemented. After that, no study actually published on MAC. So these were the loopholes in all these published studies, similar to that of Ambrosol and Guaifesin. So what the evidence was? This is the Cochrane evidence published, I think, 10 years back. 3 RCTs were included, only 139 children, and all children received actually antibiotics. That was very interesting. And this N-acetylcysteine significantly decreased cough, but that happened actually after 6 to 7 days, which is very kind of like unusual. And the viral cough, like acute cough, usually try to subside by 7 days. So we don't know whether it is the kind of time phase phenomena or just maybe the effect of the drug. So very difficult to know. And the safety, many children were included. And when some trials included children less than 2 years, they found that there is paradoxical bronchoria. Almost 86% required hospitalization. So that is applicable to all OTC mixture. They should not be used in children less than 2 years, because almost all, they increase or they cause paradoxical bronchoria and increase secretion. And for a 2-year-old child, children less than 2 years, it will be very difficult for them to take a copious amount of secretion. So they may land up with problems. So that's why all the guidelines, they tell that we should not think of using these medications in children less than 2 years. Another interesting drug I found, that is the erdostin, because it is the drug most commonly used in adults. I have seen many companies promoting them. In fact, I attended NAPCON a few days back, and there was this large banner mentioning this drug. So I just tried to see whether this drug actually is beneficial in children or not. And so when I was kind of going through the literature, I could see one multicenter RCT, including children 158 of age 2 to 12 years. And there were 2 arms. One arm gave erdostin, the second one gave amoxicillin plus erdostin. That means with antibiotics for 7 days. And interestingly, there was a 47% decrease in cough by day 3 in erdostin group. No adverse events were noted. So this is one trial. So very interesting finding. In future, we may see more trials on this drug because it is commonly used in adults actually. Regarding other drug, that is Dornase alpha, I just showed. This is a very popular drug in cystic fibrosis. So also used in some case of bronchiolitis. So I was going through the evidence, and this is the evidence that was published in Pediatric Respiratory Review, one of the reputed journals. And they found that oral or nebulized NAC or nebulized Dornase alpha, they have no role in bronchiolitis. So they should not be used. And this is the chest guideline that was published in 2017 or 18 regarding pharmacologic and non-pharmacologic treatment of for acute cough associated with the common cold. And they blanketly do not recommend any kind of OTC mixtures either in adult or pediatric population. So expectorant and mucolytic in acute cough, part the evidence shows. So till now, what we summarized, almost all trials are of small sample size, poor methodological quality, conducted before this ICA-GCP came into place. Majority showed beneficial effect and mostly clinical without an objective measure. So cough count, something like that. Patient symptoms. So there is no critical objective measure that will tell that, okay, these drugs are actually beneficial. Significant heterogeneity in the population, children from 1 month to 18 years were included, underlying diagnosis, old nomenclature like spastic bronchitis, something like that. So very interesting things were included. And disease conditions were not uniform. Like in a single trial, 2-3 conditions were included. and varied dose was used, varied duration, route of administration, formulation. No data in children less than 2 years. No expert evidence for OTC mixture. So neither the evidence support it nor the experts. Hydration potentiates their effect. It has been shown in the animal models, and almost all studies they mention that hydration should be maintained if these drugs are going to act. So effect purely because of the drugs may be like that of the placebo, as Dr. Ankit was telling, because placebo sometimes has effect. So these drugs may act as a placebo because everywhere we are focusing on the hydration part actually. Majority of the observation studies and pharma-sponsored trials, positive effect have been shown consistently, which is very unusual. Okay, there should be any negative studies, but we don't know whether they have been published or not. So these are the published studies, and it is hard to believe because uniformly all observation study and pharma-sponsored studies, they have shown that they are beneficial. So why physicians are prescribing even if weak or no evidence? So the reasons are here. Age-old practice. Okay, so people are using it, so that's why they're using it. No critical summary or appraisal of the available evidence was available till late 2000. Even if the trials were published in 1970s, 80s, there was no critical summary available. And the first Cochrane review or the first systematic review Cochrane tried to publish, it was in 2001. But how many know that this evidence is available? How many are actually aware of it? We don't know. Parental pressure as cough is troublesome and no single treatment provides immediate relief, buying time for natural cause to take over. That's why people are prescribing. Pressure from pharmaceutical companies, fear of losing patients because you have to give something. If no expectorant or mucolytic, then what to prescribe? So then personal experience comes. People tells that we are practicing since this many years. We have seen that some children respond. But yes, some children might respond, but which group we don't know. Because if you see the viruses, their mechanism of action is different. Not every virus is acting uniformly. So there is some difference. Okay, so you may find some benefit, but how to believe that? So then what is the way forward? What we should do or what should be done and what we should remain? So after reviewing all the evidence and going through the pathophysiology, no blanket prescription of expectorant and mucolytic in acute cough. I am using the word blanket, not in all cases. Children less than 2 years are at risk of adverse events, so do not think of any kind of OTC mixture. OTC mixture to be avoided without a thought, no combination. Why you are using combination? It is not required actually. Okay. Adequate hydration provide benefit. Natural demulcent have some role. I am not discussing that, but studies have shown, even the Cochrane and all systematic review experts, they are telling that you can use the demulcent. If wet cough with wheezing, nebulized or inhaled bronchodilator would benefit. Prolonged post-viral cough more than 7 days without much improvement may indicate underlying allergy, bronchospasm, or other disease. So you can think of trying a bronchodilator. Again, I'm not giving any recommendation. Okay. So this is the take-home message that you should take while managing any child with acute cough. So thank you for your patience hearing. Already everything is in your in front of you. So you have to decide. And I'm really sorry that I cannot give you a clear-cut recommendation of any expectorant or mucolytic in acute cough. But hydration consistently, like in the pathophysiology and in studies, it has been shown that to maintain the hydration, so these things will improve over time. Okay. Thank you so much for your patience here.
So, Prashant, you can stop sharing. So, Dr. Rashmi, thank you very much for an excellent talk. And I think, again, there are two important takeaways from your talk. First of all, is that all the studies on expectorants and mucolytics, they are all done before 2000, which indicate that these products are of no relevance in today because they have got no evidence. So I think one clear message which you are given is that these drugs have got no indication in management of acute cough. And whatever OTC combination will contain this product, I think they should not be used for managing pediatric cough. I think you're given a very clear message. Second thing comes out of from your talk is that there could be some role of use of bronchodilators. Of course, again, there could be a lot of discussion on this particular aspect. but some children with post-viral cough and wheezing, probably some studies or some clinician might be using bronchodilator with some benefit which could be questionable. So thank you very much, and we'll again come back to you after the panel discussion. So at the end of this particular talk, we have a panel discussion. Now, what basically we are going to do with this panel discussion is that I'll be taking three straightforward, simple cases of viral respiratory infections, and these are the cases where I've treated in the past 1 month. And what I did, it might be wrong. Whatever I did, I'll be telling what did I do, what were the outcomes. More importantly, we have got very senior pediatric pulmonologists on board. We have got Dr. B.S. Sharma, who is pulmonologist at Jaipur. We have got Dr. Jagdish Chenappa, who is pediatric pulmonologist at Narayana, Bangalore. We have got Dr. Indu from Dr. Kasar CC, Mumbai. We have got Dr. Rashmi Kapoor. She is from Regency Hospital, Kanpur. And of course, Dr. Jat, Kararan Jat, who is from AIMS. Delhi. Now, all these people, they will not treat the cases what I'm telling you today. Why I've chosen them is because they will be treating all complex pediatric pulmonology cases, and this case will never come to you. But the bulk of pediatricians, they'll manage these cases and they'll face problems because, as I told you, treatment of pneumonia is very straightforward. You diagnose pneumonia, give antibiotic, child respond within 3 days, the chapter is closed. A viral cough can direct towards any side. It can be very simple, lasting for 3 to 5 days, go on for 10 days, 20 days, child vomiting, not vomiting, develop secondary complications like rhinosinusitis, otitis media, so many things. So and the parent, they keep on coming to you, they keep on trying to pressure on you, child is not getting better, child is not sleeping, they go for doctor shopping, come with lot of prescriptions with them, and you face a dilemma whether to stop these drugs, whether to continue, whether to introduce something new. So a pediatrician face a lot of dilemma. So we have kept these senior people to give us some clear message what you should not do and how to rationally manage these children. So I'll straight away go to presentation. I'll share the screen. So scope of discussion, we'll be discussing a typical viral cough, one case with cough with wheeze and a child with wet cough over a period of 2 weeks. What we'll not discuss is cough with underlying specific problem, and we'll not discuss chronic cough. Defining cough, again, these are all we discussed in the past lectures. A cough persists for about 2 to 4 weeks, that is an acute cough. It could be acute less than 2 weeks, subacute 2 to 4 weeks, or chronic more than 4 weeks. It could be moist, wet, productive versus dry. Again, important thing, learning point is that acute cough can be a wet cough because all viral respiratory infection, they will cause acute rhinosinusitis and bronchitis, which will lead to a wet cough. So please be very clear that wet cough doesn't always mean a chronic respiratory illness. In acute phase, viral respiratory infection will cause a short-lived wet cough, which gets all right in about a couple of days. Etiology, it could be specific or it could be non-specific. A typical viral cough, a child with viral cough, he'll have cough about 7 to 10 times in a year. And again, they could be lasting for, as I said, about 1 week to about 2 to 4 weeks. And 50% children, they'll recover in about 10 days, 90% in 25 days, and 10% will have problem till 4 weeks. And these are the children who will keep shopping from doctor to doctor, have a bundle of prescription, lot of a bag of cough syrup, and they'll come to you, not getting better, know what to do. And these are the places where general pediatricians, they face a lot of problem in how to treat them rationally. And again, as I told you, it is supported by systematic review where one fourth they will be unwell by the end of 2 weeks. Like a child who's having a viral respiratory infection, even at the end of 2 weeks, he'll be unwell, he'll be feeding less, having some cough, not able to sleep, and in case parents are distressed, and you have to give them some remedy. So we start with the first case. This is Master Arjun. And again, I repeat, these are my true cases which have been managed in the past 1 month. Is Arjun who was bought by my mother in OPD. He's a 2-year-old male child with a history of fever, running of nose, and cough since past 2 days. Occasional vomit after cough. Intensity similar in day and night. Feeding less, sleep disturbed. Other children in the family have similar complaint. Immunized appropriately, no significant parental or past in illness, and child has got no personal history, family history of ATP. On examination, he is a well-nourished child, temperature 100.2, pulse rate 110, respiratory rate 28 per minute, saturation 98, wet cough, watery rhinorrhea, throat and ears normal, no respiratory distress, bilateral air entry good, vesicular breathing, and no advanced sound. And the other systems are not normal. Now there is a small video and see how this child is behaving.
So there is no audio. You can't hear the cough.
No, no audio.
You will have to share your
No.
screen again by sharing the audio as well.
Okay.
You have to disconnect and share your slide, and when the option is share audio.
Okay. Can you hear it now?
No, it's still not there.
No.
When you
So
share
when
your
you share the screen, then there will be a pop-up and you share your audio.
no in the
You have
on
to
the
share
right
that
hand
audio.
side, on the right hand side there will be an option which you have to tick mark to say share.
Right then, I don't see any option.
It should be there. If you
Sir, you have to stop sharing first, and then
Okay,
when you are
I'll
on
stop
the
share.
screen share button, on the right hand side, you will see the option of
Correct.
share audio.
Correct. On the right hand side, very small written in the corner, it will be there. Share audio.
Select your PPT first, sir. But before sharing it, on the right hand side, there is a checkbox.
Correct.
There is a content only over the shoulder share sound. Yes.
Yeah.
Now it will be shared.
But it is not clicking.
नहीं
It is not.
आपको टिक
not able
करना
to
है
click
राइट
it.
आपको राइट टिक करना है उसमें
No, I'm not able to do it.
सर व्हेन यू शेयर योर स्क्रीन राइट साइड पे एक ऑप्शन है शेयर स्क्रीन का ना उसमें आपको
हाँ
बस टिक करना है मतलब बिल्कुल ही राइट साइड पे आपके ऑप्शन आएगा वो
नहीं वो ऊपर ऊपर कुछ में क्लिक नहीं हो रहा हूँ.
सर एक
हाँ,
बार आप
बड़ा-
फोटो भेज दो तो मैं देख लूंगा
देयर इज अ सर्कल है उसके अंदर आपको टिक करना होता है.
No, sir, I think what is happening is inside your PPT, the Zoom is not detecting that sound. So that is why it is disabled. It will not get enabled.
Okay, so then we have to do without that. Okay, so then
Yes.
we do it without
आप
that.
आदर्श को भेज दो ना आदर्श कर देंगे आप अपना पीपीटी आदर्श को भेज दो
Should I, Kadesh, should I send it to you?
Yeah, you can, sir.
Okay.
If it is taking time, so alternatively, what you
Yes,
can also do.
I've sent it to you.
Via WhatsApp, sir, or via email?
No, by mail, by mail.
By mail. I haven't got it.
Got it?
No,
Should I send you on WhatsApp?
you can, sir.
Okay.
I received on the mail.
Okay.
Yeah.
Sorry for the technical glitch. We'll just
So,
Adarsh is our IT team expert and he'll just help us out. Adarsh, could you take more time, Adarsh?
Yes, it's downloading as of now. You can proceed with the next one, sir. We can come
Okay.
back to this one.
Okay.
It will be the same problem ना कॉफ नहीं कॉफ का ऑडियो उसमें भी नहीं आएगा ना
I just we just share the screen that the child was having an almost like a constant second of cough. I'll just others will share the screen and otherwise there was no the distress. Now what I did with this child was that I counseled the mother regarding the benign nature of illness because there were almost no signs, child didn't have distress, no saturation. Then I prescribed the child honey because the mother was very distressed. The child is coughing very badly. I gave him saline nasal drops and I gave him some antibiotic. Explained the danger sign that again come to me after 3 days. I told that if the child worsens, then what exactly you have to do. So giving all these things, that I sent the child home. Now the question is that whatever I did was right or wrong. We'll discuss. So we'll start with Dr. Kendu. What is the diagnosis of this child? What do you think? Because as I told you, whenever you deal a child with viral upper respiratory infection or something like LRTI, if you don't specify what you are treating, you cannot give them specific treatment. So what do you think is the child having?
So, in a child who has been previously well and healthy, in a child who has had sick contacts at home, and in a child with a short history of more of upper respiratory symptoms, though it is disturbing his sleep in the night as well as in the day, but the type of cough that there is, it is more sounding like an upper respiratory story. It is something like a viral illness, most commonly at around 2 years of age. Rhinoviruses are the very common, and then you have sick contact, that's most likely to be a viral upper respiratory tract illness. This is what I would think.
But madam, again, upper respiratory, whether you will put the label as viral rhinosinusitis, like he's having nasal discharge, cough, or you'll put the diagnosis as rhinosinusitis with bronchitis because he's having a bad cough which is bit wet. So would you like to put, or you just put a blanket diagnosis of viral URI?
I think at this point of time, if I go back to the history, it was just 2 days history of kind of symptoms of fever, and I would just put it as a viral respiratory tract infection. But whenever you have involvement of the upper respiratory tract, like if you have involvement of the nose, there will be some amount of involvement of the sinuses as well, because it is one airway. But to call it sinusitis as such in a 2-year-old at this earlier juncture, I would just call it as a viral respiratory tract infection, and I would leave it at that.
Okay, thank you, madam. What exactly you would like to prescribe this child apart from antipyretic and nasal drops? Would you like to give this child any drug?
I would counsel the parents about the benign nature of the illness, and I would use definitely, if the child has a nose block and that is the reason why the child is uncomfortable, I would probably use some saline nasal drops for this child. Antipyretics I would definitely use if the child is having high fever, and you would generally use paracetamol only and not any other antipyretic. And especially if the child is uncomfortable, that's all that I would use at this point of time for this child. And I don't think, unless I examine the child and if the child is wheezing, then maybe I would think of using a bronchodilator, but otherwise it would be just antipyretics, a saline nasal drop, and salbutamol. If the child is wheezing. Apart from that, I don't think I would use anything else for this child.
So I think you have given a very important indication that suppose if that would have been wheezing, suppose if would have got wheezing in this wrong kind in this child, you would have prescribed bronchodilator.
Yes, I would prefer to use a bronchodilator if I document a wheeze. Though having very well understood that when you have a wheeze with viral illnesses, the response to bronchodilators may not be as optimum as it would be if a child has got asthma and that person wheezing. But I would definitely give a trial of bronchodilators. If the child settles, then I would like to continue it. Sometimes it could be the first episode of a viral triggered wheeze in an asthmatic child. It may be the first presentation, and in that kind of a situation, the child will respond probably to a salbutamol. So if I hear a wheeze, I would definitely give a trial of salbutamol.
Thank you, madam. So I think after the talks of all previous two talks, there is no role of cough suppressors. We can straight away say no, that we never prescribe dexamethasone for the child. That's absolutely no. But bronchodilator, I think that is an important issue which you have raised. So we'd like to have view of other panelists also. I'd like to request Dr. Jagdish Sinappa, what makes him or not make him write a bronchodilator in a child with acute cough? This child doesn't have any sign of lower TI, he doesn't have any respiratory distress, no chest sign, and he's having a bad cough. So would you be inclined to start bronchodilator in this child?
Yeah. So I think if you may permit me, thank you very much for inviting me. Am I audible?
Yes, sir.
Yeah. So I have a little bit of a different take on this. So I would just come up with saying that yes, this is a 2-year-old child who's come to you with an acute upper respiratory infection, probably viral. Though in the video that you showed, this child was tugging at his left ear. I do not know whether that was significant or not.
No.
But I would examine this child carefully to see whether he's got otitis media also in addition, because usually this can follow in a 2-year-old child. The next important thing in this child is, why is the mother so worried about this cough? Are for 2-3 reasons. One is this child is constantly irritable. 2, this child is not sleeping very well. And 3, this child is not eat or feeding very well. So I think these 3 things need to be addressed in addition to what you're talking about, the cough. And the reason why this child is not doing all these 3 things could be because of 2 or 3 reasons. One could be nasal block. If this child has got a nasal block, he will not feed very well. The second thing is that it could be some kind of body pain. And third is there may be some difficulty in breathing. So you need to look at all these things, whether these are the points which are causing the problem or not. If there is a nasal block, in addition to putting the saline nasal drops, you might use gentle aspiration or maybe even a little bit of steam inhalation to clear up the mucus in the nose. Because children at this age are obligate, they are nasal breathers and they need the nose to be clear. So that's extremely important. The second thing is if this child is very irritable, even if this child has very minimal fever, I would use paracetamol, especially during night time, because that's the time when children will have more pain, and you would give paracetamol a little more liberally than I would use otherwise. And the third thing is as far as the use of bronchodilators is concerned, Dr. Indu has said it very clearly. I would want to look at two things. One is, does this child have any history of atopy in the past, any history of wheezing in the past, or are there audible rhonchi which are present in this child? So if there are audible rhonchi in this child, then maybe a trial of salbutamol to see whether it improves or not. If it doesn't improve, I would discontinue also. So I think the use of salbutamol is a little bit of a gray area. Some people may use, some people may not use. It goes on an individual basis. If you see this child and then say, okay, this child has got wheezing, has got rhonchi, I might use salbutamol. That's my take on this entire thing. At the same time, please also ensure that this child gets adequate hydration. I think Dr. Rashmi Ranjan Das very clearly mentioned that hydration is very important. In addition to all the things that this child has got, this child is going to vomit. This child may not take adequately. So please ensure frequent small feeds. So that will see that this child is well hydrated with passing adequate urine. So these are some of the things that I would do in addition to the other important thing is to, of course, counsel the mother. See, the other important thing is that mothers will get, once you give them a salbutamol syrup, they might misconstrue that you're giving it for cough. And you have to make it very clear that this medicine is not going to do anything to the cough. It's only going to keep the child comfortable. So the communication to the mother as to what your medicine is going to do is very, very important. Otherwise, what happens? They go with the misconception that dawa de diya hai, because the child will become all right, cough will become all right, but it is not going to do anything to the cough. So these are some of my points as far as practical.
Thank you, sir. Thank you, sir. The excellent answer, sir. Madam, you wanted to make a point.
Yeah, there are two things that I want. I completely agree with Dr. Jagdish for all his points. The one thing is about use of steam inhalation. I'm very skeptical that we should use steam inhalation for a baby of this age. I have seen more burns rather than benefit. I do understand it can open a blocked nose, but I'm really very skeptical on using steam. The only place where I use steam is when I'm sure the child has a sinusitis and is an older child, but I generally would not prefer to use steam. The other medication which is now available in the Indian market is, I was hoping that some of the previous people who spoke would speak about it, is oral glycerol, which is available. Now, oral glycerol has been used even internationally. There are a few studies on it as a demulcent for a throat. Now, if you have a child who's really having an irritation in the throat and is continuously coughing, now oral glycerol is even cleared for use in babies about 3 months of age. Maybe if I have a very uncomfortable child, I would give a go at oral glycerol. I have used it in the last 3, 4, 5 months that it has been launched in the Indian market, and the results are quite good.
Yes. Tradition, you wanted to make a point.
So one simple way of giving steam inhalation is to fill the bathroom with steam and take the baby. You don't need to give, you don't need to put the baby under the pot and then give the steam inhalation to get burns. You can fill this bathroom with steam, take the baby inside for 5 to 10 minutes and come out. That's good enough.
Yes. Rashmi madam, you wanted to make a point.
Yeah, I just wanted to second Indu's comments that I would not advise steam inhalation for reasons that I have seen burns in many children because of so many ways to get burned by steam. I have seen a child's face completely being burnt, and I've seen child tripping over the vessel that has steam. So, and moreover, steam is a big, huge particle which wouldn't even go into the nose. So, generally, steam has, like in my practice, steam has no place in children. What we use in India less and less is the nasal aspirator. So it works wonders in small children. You put saline nasal drops and aspirate it with the nasal aspirator, which is available.
Okay, so thank you, madam. So we have got some clarity about the drugs not to be used. We get definitely steam inhalation is not to be used. We don't have to use any cough suppressant like dexamethasone or levodopa. Some cases we can use salbutamol, particularly if there is wheeze or there is underlying atopy, then I think this thing has come. Now, other two drugs which are commonly used are antihistamines. And I like to ask Dr. B. H. Sharma sir, what is the role of antihistamine? Like this child is having a lot of blocked nose and running up nose. So would antihistamine work in this child?
Sir, as far as this case is concerned, this is a typical case of acute viral upper respiratory infection, and to classify anatomically, it is difficult because by nature the viruses are having a widespread or a diffuse involvement of the respiratory tract. So in this case, the using antihistaminic would be of no use because the pathology is not only the histamine causing the release of the secretions and the lot of nasal blockade and those. There are a lot of other cytokines involved in the inflammatory pathways which are responsible for making the rhinorrhea and the inflammatory edema. So as such, the antihistaminics have no role in treatment of a common cold like this child is having.
Dr. Jad, if this child had a history of atopy, so like he had a strong history of atopy in the parents, would you use antihistamine? Like it could be an first episode of toxic rhinitis. So could you use antihistamine in a child with a very strong history of atopy?
Yes, sir. This
Dr. Jad.
I agree with the all panelists. But just emphasize the one thing regarding the already discussed this steam inhalations. So please avoid this one very thing. And one more reason how to why to avoid these steam inhalations, because children don't control the distance from the steam. Parents hold their head and they keep the near the steamer. That cause the burn. That is the one reason already have emphasized. Regarding this antihistaminics, definitely, sir, if we are saying the past history of the recurrent symptoms are there. So this past history very important. Suppose past history suggestive atopy or family history atopy is there, then this will be helpful. Especially also if there is a troublesome nasal symptoms, means there's a persistent nasal discharge. Persistent nasal discharge, that may be very important indication there. We this antihistaminics may be useful, but again we have to avoid the combinations. Don't give the combinations. Suppose this fever there, use the alone paracetamol. If there you want to use this antihistaminics for the troublesome nasal symptoms, then use the alone cetirizine, not any combinations. They don't combine the medications for the one indication. Suppose you want to give the antihistaminics, they don't give the combination of the antihistaminics, the antibiotics. Similarly, don't use the combination of this antihistaminics, and other drugs also. So we have to use the individual drugs based on the for the individual symptoms.
Absolutely, sir. So I think you have made a very important point is that if there is no history of atopy and appropriate, like a child of 7 months, 8 months will not have rhinitis. Definitely child of 2 to 3 years, where there is a recurrent history of upper respiratory symptoms, family history of atopy, where you think symptoms are allergic in origin. Definitely you can use isolated, not as a combination of cough mixture, but isolated antihistamine you can use. But again, that will relieve only nasal symptoms. They will not act on cough at all. So I think we have got some very clear messages regarding what to use and what not to use. In the last group of drugs, I'll like to ask Rashmi madam, decongestant, like there's a lot of congestion in upper respiratory passage. So drugs like phenylephrine or pseudoephedrine, or like some doctors they want to prescribe antivirals in a flu season where they'll prescribe oseltamivir for a child having bad respiratory infection, although not very sick. And then they putting things like they put nasal drops like oxymetazoline and all these things. So what is the role of all these drugs?
The decongestants have generally no role because potentially they have side effects. This child is already not eating anything, and all these decongestants are likely to produce dry mucosa, and the child will further not eat anything. He might have side effects of all these drugs, and that may worsen the situation rather than improve it. So one should refrain from using all these drugs, and there is no role of antiviral like oseltamivir in this case because this child is not very seriously ill, and any child with any viral infection will not be having influenza. So we should refrain from using oseltamivir either in this case. Well, sometimes the sympathomimetic nasal drops of xylometazoline and which comes in a lower concentration in that is in which can be used in infants and pediatric just for a day or two, which when the child is really not feeding well, despite because of the nose being blocked, and despite using the saline nasal drops, which really help, saline nasal drops and followed by aspiration. But sometimes these sympathomimetic drugs, once or twice in a day for a day or two, may go a long way in improving the sleep quality and also enhancing the child and promoting the child to have more feeds. Well, there is definitely a role of honey because honey acts as a demulcent. So it forms a layer in the posterior pharyngeal wall. It may, help reducing the reflex cough also. And I was seeing in the chat box what's the dose of honey. So there are different doses. They say 2.5 ml of honey for just 2 days and would go a long way. And after 2 days, honey also has no role in treating the cough.
Yes. Thank you. Pindu madam, you wanted to say something?
I'm a little skeptical on honey too. The reason why I'm skeptical is we don't know the quality of honey that we get. It could be contaminated. We could have problems. Honey is nowadays. There was a study which was done recently, which showed that what honey we get in the market today, 70% is sugar. So I really don't know. There are some brands in the market called Honey Tuss. I really don't know about them too, but whether that can replace honey. So therefore, I find oral glycerol a better kind of a regulated demulcent. Though I know traditionally in the Indian traditionally Indians have used honey, and it is a demulcent. There's no two things about it. But because of the lack of kind of standardization, I would be a little skeptical. So therefore, I use an oral glycerol. The dose is from 3 months onwards till infancy. It's 5 ml TDS, and above the age of 1 year, it is 10 ml TDS. It's a blanket dose. It does not cause diarrhea in the dose that it is It is given because that is the only side effect that you would worry about. So this is my thoughts. If honey would be pure and good, maybe I don't know, but I'm not sure what we get.
So I think, madam, you have made a very valid point. The until we have got, because a lot of studies they quote honey as a relief for cough, but definitely until it is of pharmaceutical quality, when it is regulated by FSSI, where we got proper regulation, then only we can prescribe it more confidently. So I think you made a very valid point. So I think after all your inputs, the model picture for this child would be the diagnosis would be as everyone was told: viral upper respiratory infection, no antitussive, no antihistamine, bronchodilator plus minus depending upon the child, deconsistent, no antivirals, sympathomimetic drops, as Dr. Rashmi has told. Sometime in some children you can use, and saline nasal drop definitely you should use more frequently. Honey, you should be very cautious probably whenever you are using it, so that you are sure about the quality. Dr. Sharma, you wanted to make a point?
Sir, for prescribing the nasal saline drops, I think we must very clearly explain to the parents. Normally, they put 1 or 2 drops in each nostril. I think that is not working at all. It has to be a liberal amount of saline, which the aim is to dissolve the crust and to make the nasal passage clear, to get the ciliary functions better, and at the same time that removes the viral load also. So it has to be liberal use of saline rather than putting 2 drops each nostril.
Okay. Kundu madam, you wanted to make a point?
No, sorry, I forgot to put my hand down.
Okay, so now we have got a model prescription of a viral upper respiratory infection. Mind you, it is an upper respiratory infection, and if you manage in this particular manner, definitely the outcome would be good. So after the child was called for follow-up after 5 days, the fever had subsided, child was getting worse, and now the cough was more in night. Again, he is still vomiting 1 to 2 times in a day. Nasal discharge is still persisting and has become slightly yellowish. Not feeding well again, sleep disturbed due to cough. Again, examination, child afebrile, pulse 100 per minute, respirated 28, SpO2 99, yellow mucoid nasal discharge, wet cough, no distress, scattered, fourth expected bronchi. On 5th day of the presentation, again, because initially I did prescribe everything, and it was just an counseling. And now he has come after 5 days, and I could find scattered rhonchi in his chest. Now the mother is distressed now. Already 6 7 days have gone, and she wants quick relief now because she'll not wait by only counseling. So issues are before us. Cough getting worse, more in night, some amount of wheeze. Should we add bronchodilator? Disturbed sleep. Should we add a cough suppressant because who was the working parent and they feel that their sleep is getting disturbed? Is it acute bacterial sinusitis because again the discharge has become a bit yellow? Should we add antibiotic in this child? And would you like to have any test to be done? Rashmi madam, could you add a bronchodilator?
Yes, I will definitely add a bronchodilator here. Like we should always try and discourage use of nebulizer, because first thing we will ask them to buy a nebulizer, which is really a bad thing, not a good advice to be giving. And I would refrain from using an oral salbutamol also, because if you prescribe an oral salbutamol, then rest assured for every cough that the child will have, they will have this considered as a cough syrup. So it's better to give them a bronchodilator through spacer and mask, and that would be better and give time to them to teach. And no suppressants should be added to this child. And yellow coloration of yellow mucoid discharge is not an indication that this is a bacterial rhinosinusitis. So no antibiotics are needed at this time, and no investigations either are needed at this time. We should
Okay.
just send the child with the bronchodilators with spacer and mask, and ask the mother to maintain good hydration in this child at every point of time.
Okay, so thank you, madam. You have raised a very important point regarding the root of bronchodilator. We are in agreement that bronchodilator has to be used at this particular stage. But the root is important because although you have made a very rational point, use of MDI spacer, but it is almost impossible in practice of anybody who wants to give MDI spacer for the child for the first time coming to you with URI. Not possible at all. We have to use oral bronchodilator, and this is a practical reality. You may talk to any specialist across India. It becomes impossible. So I think at this point, I think this is very debatable. Like trying to use an MDS spacer for the first child, you require a very aware parent, and you require a very good doctor-patient relationship where you can prescribe your MDS spacer. It becomes very difficult. I'd like to ask Kagaran Jat sir, would you use an oral bronchodilator in this child, or you will use MDS spacer? What do you do in AIMS?
Yes, sir, I agree with you. If child is coming in the only first episode of the CURI and is the 1 week only symptoms, so very difficult to convince the parents also, even it may not be effective. But one thing regarding this thing, wheezing. But if the wheezing is definite, then we need the bronchodilators. So second thing comes, if there is suppose family history of the some, although child has the first episode, but there is family history of the atopy, then more likely to the wheezing, there may be role of the bronchodilators. If no family history, only this mild wheezing there, so in the some cases we can use the oral bronchodilator. Then no use the harm. In some cases we also use the bronchodilator, because you are very right. Very difficult to convince the parents to use this MDI with spacer in the with first episode of the illness. And I agree that no role of the any cup suppressants. And regarding the antibiotics, because now we are seeing the 2 days previously, now the almost is the second week of the illness. So if they usually most of the times that this URI improving the 5 to 7 days, but instead of the improving is worsening after the 1 week of the this illness, then we should do the think of the complications. And most common complication of the any URI are the one in the otitis media that Dr. Chinnappa discussing. Another otitis media, another complication the this sinusitis. All this age is the less common as 2 years, because the just say Megiri sinus is just developing. Although it's happened 2 years, but just developing the this. So we should think complication also in the second week of the this URI when it's not improving.
So thank you, sir. So again, we get a very clear message that you can at this stage you can use an oral bronchodilator for a short period, telling the mother that this is not a cough remedy not to be used in future coughs, and this is used specifically because this particular episode is having some amount of a cough which will respond to this particular medication. No role of antibiotic at present because it is not unnecessary. Ear were normal. there were no role of antibiotic, and I don't think we need to do any test at this particular stage. So what did we do that? We did start the child on oral salbutamol syrup and continue with honey and nasal drop. Consult mother regarding the time taken by viral cough to resolve, and again called after for 3 days. After 10 days, child started getting high grade fever with 101. Since past 2 days, cough worsened, wet again, typhoid again, wet both in night, occasional vomiting with cough persisting, sleep feeding disturbed. Again, the nasal discharge was yellow mucoid and the ears were normal. On examination, child was again febrile, 100.4, respiratory was normal, pulse rate was slightly more, SpO2 was normal, chest were absolutely fine, and he had mucopurulin discharge from his nose, and there was a postnasal drip on ortho examination. Other systems were absolutely normal. So why cough getting worse? I think this is straightforward. Child probably had developed a complication of bacterial sinusitis, and definitely, I don't think there is any doubt in this thing that we need to add antibiotic in this child. We did add antibiotic in this child in form of co-amoxicillin, stopped the salbutamol suspension, continuous saline drops, followed for 3 days, and the child showed good improvement. The cough was resolving, and the child got better. We continued antibiotic for 10 days. So I think what basically we get from this particular case is that upper respiratory infection, they are caused by viral infection invariably, and they cause sinusitis and bronchitis and viral bronchitis, which can lead to a wet cough. So trying to pinpoint which particular part of airway you're trying to target. Like if it is more of bronchitis, probably you will like to add some bronchodilator. If it is more sinusitis, I think giving a more non-specific therapy in form of nasal drops and antibiotic would help. Antidepressive, bronchodilator, antihistamine, they have got absolutely no role to play. Please, because I share a prescription, I see almost every day a child of 1 month, 2 months giving oral drops, antihistamine, cough cold mixture. I see it every day and I stop these prescriptions. So my request to all the viewers is that please don't use this drug for treating cough in small children, because they're going to cause lot of harm and they're going to cause lot of side effects, and they lead to a lot of problems. Writing prescription, specific diagnosis will help you to write a nasal prescription, and definitely you can tailor your prescription depending upon what you are treating. Presence of wheeze, as everybody agrees, they can respond to bronchodilators. Even if there is no history of atopy, a wheeze can give you some relief in the cough, and definitely you can use bronchodilator. And a rhinosinusitis is a very common complication of viral URI. So beware. There are very stringent criteria to diagnose rhinosinusitis. It is not that you diagnose rhinosinusitis in any child with upper respiratory infection and cough. So there are stringent criteria. You can go through literature. We don't have. It is not the topic discussion today. But if you diagnose rhinosinusitis, then you are justified in writing antibiotic. Otherwise, no role antibiotic in viral upper respiratory infection. I think Dr. Chinnappa wants to make a point. Yes, sir. Please.
Yeah, I want to ask a question on whether you would add ambroxol here.
No, sir. No ambroxol. Again,
Wait a minute. The evidence suggests that in the second week, if there is a wet cough and when there is significant mucus, they could add ambroxol. Now that was also mentioned in the talk which was given by Dr. Rashmi Ranjan Das. Though the evidence is low, if you look at most of the data, it suggests that ambroxol may be tried in the second week with a wet cough.
Right, sir. Okay, sir.
So that is one thing which we need to look at, whether it is useful or not.
Okay. Kanaram, sir.
Sir, just want to add one thing. This child has this vomiting after coughing. So this is the not uncommon symptoms. Ki many children have this vomiting after the cough. So any prolonged coughing can cause the vomiting, but some children have associated reflex. That is suggested by in most of the children there is history ki whenever they have cough there is a vomiting. Second thing, this cough worsens just after the sleep. As soon as the child sleeps, there is a cough is worsening. That again suggests the reflex. So if there is such history, then adding this PPI like the lansoprazole may be helpful in reducing the cough.
So it's a point well taken, but this child never had any such symptom in the past, and this was only a vomiting after a bout of cough, not related to feeding. So we never thought of any PPI or any reflux in this child, and I think it was just a manifestation of severe upper respiratory inflammation, and that lead to cough. It was not related to that.
Not for this child, but in some children may have such history. Whenever they have cough, they are vomiting also. and that these symptoms worsening after the sleep.
Yes, sir. Point well taken, sir. Yes, Chandu madam.
I would caution against using anti-reflux treatment so loosely. Because I've seen that the reflex to treat reflux is like is unjustified in most. Post-acid vomiting is common, definitely common, and I feel that using anti-reflux treatment is a double-edged sword. There are pointers to say that prolonged use of anti-reflux treatment or even recurrent use actually increases the risk of infections. And therefore, I would not use anti-reflux treatment in such a simple URI at all, even if there is
Agreed.
post-acid vomiting.
Agreed, madam.
I would
Agreed.
give a clear, I would really be skeptical about it. I'm open to a criticism, discussion, whatever, but I would not use anti-reflux treatment.
Agreed, madam. I think this child will not use any anti-reflux treatment.
Any other routine, I think we use anti-reflux treatment very loosely. The indications for anti-reflux treatment are far by few. And
Yes, so I think if they were.
a 2-year-old child, I don't think reflux is a problem here. The problem is post-acid vomiting.
Absolutely clear. You are there, Adarsh? Adarsh, you are there?
Yes, sir.
Adarsh, you are there?
Yes, sir, I am here.
हाँ प्लीज आप मुझे पहला वाला बता दीजिए कॉफ, उसके बाद दूसरा वाला केस है उसका भी एक बार बता दीजिए कॉफ। आप एक बार तीनों को बता दीजिए, तीनों का कॉफ। Thank you. You can show the next video also.
Dr. Rawat, this child's voice is affected.
Sir, ear was all right.
No, his voice is affected. His cry is affected.
It looks like a laryngotracheobronchitis.
Yes. But sir,
this is a kid I would think of bronchodilators very early on. And
this is case number 2. We can't see the video. Adarsh, we can't see the video.
You can't see the video, sir?
Huh. First case had no chest sign. There are some questions in the chat box. I'll again repeat. The child, entire 10 days, there were no chest sign, there were no distress.
It seems there's only audio in the second case. It seems.
It was just upper respiratory.
Sometimes you have to even if you don't hear, sometimes you have small airways involved. And therefore, many of these kids may be wheezing. So
Madam, there was no distress. Saturation was all right.
You need to follow them up. You need to follow them up. And
तीन में follow किया. He came second, third, fifth day and 10th day again.
Go by the history, family history, and if the cough is worse in the night, early morning, then even if you can't hear a wheeze, sometimes you may benefit by giving an oral bronchodilator. And I would think for the first time I would give an oral bronchodilator. Unless it's a family history of asthma, they're used to inhalers, then it is easier to convince. Otherwise, it's impossible.
Adarsh? Yes. Now this child has got respiratory distress also. If you see, there is tachypnea. Then you can quickly show the third child also. We'll go bit fast. Others you can show the third child also. This is a child 7-year-old with wet cough. 20 days. This was sent by the parents when the child was sleeping in the night. There is no distress, but he had coughs in past 20 days, both day and night. and again a wet cough. Okay, Adarsh, thank you. So we quickly go on the second, third case because there is not much time left. We already are running late. Why it is not moving?
It was showing, sir.
It is not moving. Okay, so now you have seen the video. This is Pinky, 7 months old, brought by mother with complaints of fever, cold, coughs in 3 days, fever, colds in 3 days, coughs in 2 days, and fast breathing in 1 day. Cough more worse in night, no vomiting, sleep disturbed, feeding normally. Neutral period, uneventful, no significant past illness, immunized to date, no ARI in family member, no history of ATP. Examination, temperature 99, respiratory rate 55, which was tachypnea. SpO2 was normal, respiratory system, there was watery anuria, tachypnea, mild circulatory contraction, bilateral polyphonic wheeze. You have seen this action. What did we do with this child? We diagnosed the child as a child with acute mild bronchiolitis, gave her sedation with 3% saline, gave her saline nasal drop, paracetamol drops, no honey, counseled the parent regarding the course of illness and danger sign and asked them to follow up after for data. This is what we did to this child. Question for the panel is, what is the diagnosis? Action in ER, we will give oxygen, nebulization, drugs, 3% saline, salbutamol, antibiotics, bronchodilator, antitussive, antihistamine, saline drops, and honey. I think we can start with Dr. Sharma. Sir, please unmute करिए sir. So please unmute. I request you to be brief and quick.
If this is in first episode without previous history, it is a clear-cut case of bronchiolitis, then I don't think there is any need for giving an oxygen or nebulization, and I don't feel in mild variety we need even the 3% saline nebulization also. And there is no question of salbutamol, even if it is a wheezing because of bronchiolitis, because wheezing and bronchiolitis has many other reasons other than the bronchoconstriction. There is no role of antibiotics. There's no role of antitussives, there is no role of antihistaminics, and I think nasal saline drops are still needed for this child also, because you need to keep the nasal passage patent for making comfortable breathe and feed. And honey, I think, is not needed for such a small child.
So I agree with you that this is mild bronchiolitis. Only confusion is that whether you should nebulize because if you see the lecture of Rashmi Das, there was a comprehensive review which indicated that giving 3% saline would prevent hospitalization and lead to recovery. So I think there is some evidence of use of even 3% saline in a child with mild bronchiolitis. We'll ask Rashmi Madam, what is her view?
So this child was feeding well. So first thing is this child doesn't need hospitalization right now. And if the child doesn't need hospitalization, why should one send the child home on 3% saline nebulization?
No,
He'll have
it
to
was done in
buy
the
a
clinic. No, madam, no, madam. Done at the clinic and then sent home on oral medication. There was no, it was not given at home. This was given at my clinic.
So there is generally no clear-cut evidence of any of these drugs for bronchiolitis. I would generally send the child home. If I were treating this child, if I was treating this child, I would send the child home with saline nasal drops and adequate hydration and call the child back again after 2 days.
Dr. Jad,
If
this
it is.
child can come to your outdoor in AIMS with a mild bronchiolitis. What you will do?
Yes, sir, this is a mild bronchiolitis, nothing required except that this nasal drops and if there are fever, salbutamol. And regarding 3% saline, the Dr. Rashmi discussed the systematic review And in most of the studies, it was used for moderate to severe bronchitis, not for the mild bronchitis. And even the systematic review, not a good systematic review. That is many the fallacies also in the systematic review. And majority study was only from China. Largest study that was keeping the bias toward the benefit of the 3% saline. So at present, there are no specific role. Only in the very severe cases where child is deteriorating, we can use this 3% saline, not otherwise.
Okay. Sharma sir, you want to say something?
Yeah, what Dr. Rasmi was mentioning was the studies of hypertonic saline in the hospitalized children, not for single ER dose. I think he was referring to that. And once we are not keeping the child in the hospital, how can you nebulize him with saline? And putting one hypertonic saline nebulization, I don't think is going to serve any purpose.
Jagdish sir, what you will do? This child is coming to you in a OPD. A child with mild bronchiolitis, 7-month-old child. What you will do?
7-month-old mild bronchiolitis, just only counseling and symptomatic treatment with nothing else. You might give a trial of salbutamol nebulization because this is the first episode of wheezing, but otherwise no other treatment.
You will not give 3% saline nebulization?
No, I will not.
Okay. Kundu madam?
I agree with Dr. Jagdish. If this child is wheezing, I will definitely give a trial of bronchodilation. It could be a nebulized form or it could be oral form, depending on how the child is. And if the child responds, then I would send this child on oral bronchodilators. Here it is extremely important to see if this kid had any high risk factors. If there are any high risk factors, then I would keep this child for observation. That's my second point. And third point, I would give all the danger signs to the parent, because bronchiolitis kids, I would also look at his saturation before I send him home. And bronchiolitis kids can deteriorate very fast sometimes. They just go, this looks like a classical, like an RSV bronchiolitis. So I just need to, educate the parents about all the danger signs.
But I think, madam, what you and Dr. Chinnappa are raising a point is that use of salbutamol in bronchiolitis, in a mild bronchiolitis, I think it is not indicated, because if you read any literature, it is indicated in a severe bronchiolitis where you are justified in using salbutamol nebulization because it could be a first attack of asthma. But a child with mild bronchiolitis who is otherwise maintaining a normal saturation with some wheeze, I don't think that we should tell on this platform that use a salbutamol nebulization, because it will be wrong. Unless it is a severe attack of bronchiolitis which requires hospital admission, where you are giving him treatment in a hospital, you are justified, because even books they say that. But I don't think in a clinic you will offer him a nebulized bronchodilator. I like to have opinion of other people.
This child was tachypnic. Okay, if this child is tachypnic, I would give him one nebulized salbutamol, or there is data to say that adrenaline works better in bronchiolitis compared to salbutamol. Maybe I would give him either adrenaline or salbutamol nebulization in front of me. I would look for response. If there is good response, only then I would continue. If there is no response, then there is no role at all. There is no role for continuous bronchodilation nebulization unless there is a response, because it could be the first episode of a viral triggered wheeze in a child who may later on be an asthmatic. You never know. So that is the subsegment of bronchiolitis which will respond. I am not saying that an RSV or any other bronchiolitis will respond, but a subsegment of wheezers who present like this for the first time will respond. Okay, so and your child is tachypnic here. I will definitely give a trial before I send them this. I know where you're coming from, but this is my thought. It's open to discussion.
Okay, Rashmi madam.
Yeah, so all the trials that have been done are done in sick children who are admitted. So the trial for adrenaline, the trial for 3% saline, the trial for salbutamol, they've all been done. There have been done a few RCTs also for this, but they all concluded that they were not recommended. Nobody could recommend any of these if like the results were equivocal. So, and they were all done in children who were admitted, not in children who were, not sick and were to be sent home.
Sharma sir?
Yes, sir. If as we see that every child with bronchiolitis is going to wheeze. So if we are going to give this message that when the child is having wheeze, give bronchodilator, I think would be absolutely a wrong message. No, every child with bronchiolitis should not be given with that. As Dr. Rasmi has said, that a child who has been admitted is a sick child and who is not responding to routine symptomatic therapy, means oxygen is the primary treatment. The child not responding to well hydration, no fever, nasal passage clear, there is no oxygen requirement, I don't find any reason to give him unless the child has a very strong family history of it. That is the only group of children.
Absolutely, sir. Kanalam, sir.
Yes, sir. At this point of time, only the two interventions that are found to be very useful in the bronchiolitis, the one that Dr. Sharma mentioned, that the oxygen if child hypoxic, and that the hydration if child is not able to feed well. Otherwise, no role of the other medications, including the bronchodilators. So the wheeze is the, as sir clearly mentioned, wheeze is not indication to use the bronchodilators. So please should avoid the, especially in this mild case, mild bronchiolitis, no role of the any bronchodilators.
Jagdish, sir.
Yeah, I think I agree with all the panelists. My point is when a child comes to you with fever, runny nose, cough, and wheeze, you don't know right at the beginning whether this is bronchiolitis or the first episode of a viral induced wheeze.
Correct.
So before you label this child as bronchiolitis and start looking at treatment for bronchiolitis, you're treating a child with wheezing. And for that, you do not know whether it is this or that. So give a trial of salbutamol. If the child improves with that, continue with it. If it doesn't, diagnose bronchiolitis and stop it. There is no problem there. But don't label a child who comes to you with the first episode of wheeze as bronchiolitis itself. You do not know which one it is, isn't it? So I think the point is, with what Dr. Indu and me are saying is, labeling comes later. Treatment comes first. You can label as whatever you like later on. But at the moment, you need to relieve this child of his wheezing. So give a trial and see whether it works or not. No?
Okay. So thank you very much, sir. So I think with this view of all the experts, that diagnosis definitely is in mild bronchiolitis. Action in ER, we are sure that salbutamol plus or minus. I think in the balance sticks towards not using it until unless there is strong family so atrophy or till that time probably will not use it. Again, 50% saline, all the experts are view that for mild cases you may not need and only severe cases you need it. Antibiotic, everything is you should not use it. So I think the only treatment what you require for the child is good counseling, hydration, explaining that the child danger signs, keep the nose clean and then call the child for follow-up. So this is what we did. Child follow after 3 days. Child is afebrile, cough persisting, more worse in night, occasional vomiting and feeding normal, sleep is bit disturbed. On examination, again, the respiratory rate was 58 per minute, slightly tachypneic, pulse rate 98, maintaining saturation well. Respiratory system, again, they were still persisting mild subclavicular retraction and they were diffuse polyphonic bronchi with there. Issues, child is still having persistent cough with wheeze, there is no hypoxia, sleep is still disturbed. Should we again give it 3% saline nebulization because again the child is still having some wheeze and cough. Again, we should give them salbutamol nebulization or oral all drugs to this child. Give them oral bronchodilator at home, antibiotic to this child. Cough suppression. I think if this rule of last three are definitely are not there. Antibiotic no role. Cough suppression and antihistamine there is no role. Saline definitely good. So I think basically in this child we want to know from the experts whether at this stage at 5th day of follow-up child is still having wheezing and tachypnea. So should we give him 3% saline nebulization or salbutamol or both? And when send the child home, we should give them oral bronchodilator. What you should do? Kundu madam, what you will do?
If the child had responded to the wheeze only, then I would give. Otherwise, I would just counsel this parent. I don't see the role for 3% saline nebulization because there is no hypoxia. There's only cough, right, with wheeze. Only if he had responded. Otherwise, I don't think there's a role of anything else right now.
Sharma sir.
I think I'll like to wait if the child is not worsening.
Okay. So what we did was that again we counseled the mother regarding the benign nature of illness. We reinforced the recognition of danger signs. We asked her to continue saline drop and then asked her to come for follow-up after 3 days more. cough is getting better, sleep is better, feeding, no vomiting, the tachypnea has now started settling, respiratory rate has become better, it's 40 per minute, saturation is normal, and the child had very few ronchi now, and the child did well without doing anything with a good amount of good counseling. So learning point in this child is this particular case is that bronchiolitis is a common illness, comes as a viral induced LRTI with cough and respiratory distress. Again, you classify the disease severity, mild, moderate, severe, and accordingly you will plan your therapy. In mild disease, they are managed on outpatient basis, reassurance, hydration, and saline nasal drop, paracetamol is all that needed. All are experts, they agree with this particular thing. Some cases, 3% nebulization, probably if it is more severe, you can use. Roll of bronchodilator, again, there is a bit, the expert, they don't agree. Some say, they may not say, but again, definitely there is no family history of atopy in the child where you don't suspect and allergic basis. I don't think there is any role of bronchiolitis in a child with bronchiolitis. Of course, there is no role of cough suppressant, mucolytic, and antihistamine and antibiotic. So I think this is the way in which if you manage your child with bronchiolitis, I think again the result will be good. Last case, this is an Adarsh who is 7-year-old male child brought by parent with the complaints of wet cough since past 3 weeks, child had fever and cold followed by cough 3 weeks back. It was treated with paracetamol and cough cold mixture by the GP. The fever subsided. The cold with yellowish nasal discharge persists for 10 days. Again, the cold is also better. But the cough is persisting day and night and almost with a constant pattern and disturbed sleep. In past 20 days, the cough has been the same and it is sort of bad cough as you have seen in the video. Past history of recurrent episode of fever and cough lasting for a couple of days. Treated by oral medication sometime when nebulization when the child was small. Again, till 5 years he had, and after 5 years, child is all right. So in his infancy and early childhood, he had some episodes of wheezing where he was treated by nebulization by his GP. But again, at present, child is all right in past 2 years. There was no admission in the hospital, no atopy, no contact with cough, and child is immunized, doing well. On examination, he is a well-grown child, afebrile, pulse rate 88, respiratory rate is normal, SpO2 is 99, respiratory system, he is having a wet cough, you must have seen on the video, no distress, good air entry, vesicular breathing all over, no additional sound, other systems are normal. This you have seen the video. What did we do with the child? We diagnosed the child as a post-viral cough because as you have seen in the past presentation, viral cough can be there for 2 to 4 weeks. He had a wet cough, but otherwise he had no other sign and his chest was absolutely all right. So then we again counseled the parent regarding the benign nature of illness. We didn't do any test because again this was he had no other past history. The parents were distressed because they had come after treatment from a GP, and then they had come to me for the advice, and then I gave it a thought, and then I prescribed the child levothyroxine for symptomatic relief because child had a disturbed sleep, and then the parents were also disturbed. That already 20 days have gone. So keeping everything in mind and indication of levothyroxine as a peripheral acting drug, I prescribed for the child. I gave him honey, good hydration, and call up them for follow-up. Now, question about the panelist. What do you think this case is having? Any investigation you need at this stage? Role of cough suppression because child is having cough since past 20 days, 7-year-old child, no past history. Role of bronchodilator in this child, there were no wheeze, but he had cough which was there in day and night both. Antihistamine, mucolytic, expectorant, and role of antibiotic. We'll start with Dr. Jad. Dr. Jad, what do you think about this case?
So this side, the significant past history, you mentioned that he had the similar episode in the past requiring the sometimes the nebulizer also. So in such a case, that is any child having the prolonged cough after the some cold cough, like he's the this time also is the after cold cough he has the 20 days cough, and in the past also. So here we have to keep the high index suspicion of the asthma. So for that we should perform this because this child the 7-year-old he can perform the spirometry. We should check for the pre and post bronchiolitis reversibility, and it is there then should to treat for the asthma.
Okay. So what do you prescribe? We did do test and this, but do you want to do spirometry here?
Yes, sir. I want to do the spirometry first, and then after that I will decide the treatment because this is past history similar. Many episodes of this cough in the past is there. So first,
sir, he had symptoms 5 years, when he was less than 5 years, but after 2 years it was all right. Chest doesn't have any rhonchi. Chest is absolutely clear. There is no rhonchi. It's just an isolated cough, which is wet. So
Yes,
I
sir.
don't think you will get wet cough in a child with asthma. Do you think?
Yes, sir. As we already, you also mentioned in the first case also that any viral cough may have the wet cough transiently. So it's not odd to have this. Even the asthmatic patients, if there is viral infection, they have the transiently wet cough. So this transient wet cough is not against the asthma, but even this is the asthma is very episodic. So the 2 years of the asymptomatic period not against the asthma. The child was well for the between the 2 5 There may they even by model peak also. Some children have symptoms 5 years, then it remains again the next 5 year maybe remain normal, and again after 10 years they may be symptoms maybe reappear. So these are the recurrent episodes. Especially I will think the asthma, and while I will investigate for the asthma before starting the treatment.
Chidampa sir, what do you think? How will you manage this child?
Yeah, I think Dr. Kanaram has a very important point that here, I think the first thing in the view of the past history, definitely one would do a lung function test. And based on that, decide what to do next. Now, if the lung function test shows you significant obstruction, then you would probably go the route of probably, an asthma-like disorder, which is there. But if this child continues to have wet cough, then I would look at protracted bacterial bronchitis as a possibility and try and see what to do next and treat it accordingly. The other thing we also need to look at is what is this child's immunization status. See, again, this.
Immunize well.
No, the important thing is that whether this is whooping cough starting off or something like that, that we need to keep in mind. The
Not
fourth thing we
liquid
need to the fourth thing we need to look at is what was the nature of those wheezy episodes he had in childhood. Is there any evidence of malacia there? Because we know that protracted bacterial bronchitis is more common in children who have got malacia. So I think the important thing there is to get a good detailed history, do a lung function test, maybe even get an X-ray just to rule out confounders. You may not find anything else there. But I think I would go, what Dr. Jat said is very good, that we have now waited for 4 weeks. It's time, or 3 to 4 weeks, and this is the time to look at this child more carefully, maybe get a few investigations, and then decide course of action. I would not go into just giving some kind of treatment. The other thing is regarding the use of a peripheral antitussive agent which you have used right now. I think that would work better in a dry cough than in a wet cough. So here, I mean, probably I would use a bronchodilator or even Ambroxol for some time to see whether it works or not. But I think the differentials here is probably between an allergic disorder like asthma, which is there, or an infective disorder like a protracted bacterial bronchitis. I would look at these two things.
Okay, Rashmi madam, what do you think? Short
Yeah,
answer and quick.
so right now, asthma would be my first probability, and I would go in for spirometry and FOT, etc., whichever is available, and then only. And I would rather not give any cough suppressant because one, we have very little experience with this peripherally acting cough suppressant, and second, for any kind of wet cough, this cough suppressant should not be given because we don't know if it is it's heading towards protracted bacterial bronchitis also. We may be suppressing the cough, and all the mucus with the beneficial effect of cough would have gone, and we would increase the infection.
Thank you,
So
Sharma.
and no antihistamine, no mucolytics or expectorants, and right now there is no role of antibiotics either.
Sharma sir.
Sir, unmute yourself.
Unmute. Sabine, unmute.
I think at this point of time, I would like to keep asthma as a second possibility because in asthma, as Dr. Kanaram was mentioning, that it can be there at any time. That's true. But the typical history of this patient is that the patient has an acute viral respiratory infection, which was not improving as it should have improved, and the child is having a persistent cough, which is wet. In most of the viral coughs, wet cough disappears by 10 to 15 days. But in spite of 3 weeks, the child is still having wet cough. I think protracted bacterial bronchitis would be my first diagnosis.
Kindu madam.
My thought process is, I'm sorry, totally different from the rest of the people. Now, this is a 7-year-old. Correct me if I'm wrong. I've got the age.
Yes.
By definition, protracted bacterial bronchitis comes in children below the age of 5 years. though I'm sure medicine does not follow rules and it can be in an older kid, but this is a child with a wet cough at the age of 7 years. The typical bugs which call protracted bacterial bronchitis, the H influenza, Moraxella, Streptococcus pneumoniae, and the classical age group is 1 to 5 years. Okay. Now, any kid who's having a cough like this, first of all, I will not, even if I think of asthma, I can't do a spirometry on a coughing child. If I take him in for a spirometry, half the time he will have cough in between and he will not even be able to perform the spirometry. So I would examine this child fully. And in our country, I need to 2 weeks of cough, I need to rule out tuberculosis. So I would, for this child, would take, I would investigate this child. I would do a basic CBC, probably I will do an X-ray chest. Okay. Now, if my X-ray chest shows me bronchial thickening, sometimes you can, many of these kids nowadays we see who have prolonged cough, and they tend to have, you can actually see endobronchial thickening. You can sometimes see a small area of patchy atelectasis because this is some mucus plugging which has occurred into this child who's been having cough for some time now. Okay. And then if I see something like this, and if my child has a wet cough, I will give a trial of antibiotics to this kid. After I give a trial of antibiotics and I've taken an X-ray, I've tried to rule out tuberculosis, I will give a trial of antibiotics. Even if I doubt TB, I would first give a trial of antibiotics because obviously there's no cox contact here. I would see the response of this child after 1 week of antibiotics and then take it from there whether I want to look at asthma or something else. This would be my approach to a child who has a wet cough going on for 3 weeks. So a 7-year-old, my PBB is not my first diagnosis. This is an infective cough. A persistent lower respiratory tract infection is my thought. In my country, I would rule out TB. Asthma would be my underlying. Asthma should not have wet cough. Yes, but asthma can have wet cough, can have a right middle lobe syndrome because of mucus plugging if the child is an uncontrolled bad asthmatic. But this kid was well for 2 years in between. Why should he have a wet cough with asthma?
So I agree with whatever you have told. I agree with all the panelists, and we had all these things in our mind when we approached this child. This child, we didn't, we had a PBB in mind, but since it was only 3 weeks, he was in the border zone. So we decided to give some more time to this child. We thought about TB, but there was isolated cough, no fever, nothing. So no weight loss. So we didn't think of TB. Asthma, child had episodes of viral induced wheezing in the childhood, but after that he was all right. 2 years, there was no, he's growing well, no history. So we didn't keep a history of possibility of asthma right now. And the basic problem the parents were worried about was cough. And since child was otherwise normal, we decided to give levodopa. But I think after this all discussion, I think it was wrong. We could have given a trial of only oral bronchodilator or say of Tomoxone. So I think the diagnosis we have it is post viral bronchitis. We will not label as a PV classically according to the definition. Investigation, we didn't do anything, but I think the panelists, they think that you could do a CBC X-ray, all these things like that, but we didn't do anything at this stage because otherwise all things were normal. No roll-up percent. We agree with whatever panelists are telling. Bronchodilator, we could have used it plus minus because there was a bit of wet cough and no role of antihistamine, mucolytic, and antibiotic. So this child was called follow after 7 days. Wet cough was persisting and now it has become worse, more in day and night. Again, no fever, no symptoms, and appetite was good. Examination, again, he had a normal systemic examination, there was slight 99 temperature, respiratory was 20 and SpO2 was normal. Respiratory system, he had wet cough, there was no distress and no chest sign. Issues, persistent wet cough for 4 weeks, probably worsening, any investigation. Bronchodilator, cough suppressant, antibiotic. Again, we'll go a bit fast because no time much left. What did we do with this child? At 4 weeks of illness, we decided to work with this child, did a CBC, exercise and spirometry, were all normal. So we made a diagnosis of clinical protracted brachial bronchitis for this child because all tests were now normal. And we started the child on co-amoxicillin at after for 2 weeks. Stop antacid with this child and follow up for 7 days. And on follow-up, there was a good cup resolution and the chest exam was normal. And antibiotic was continued for a period of 2 weeks. So learning point from this all 3 cases is that post-viral cough can last for 3 to 4 weeks. However, they have got a resolving pattern. Mind you, the cough is always a resolving mode. If it is persistent or it is worsening, always think it is not a plain post-viral cough. There has to be something else. Worsening cough is a red flag sign and search for the cause is mandatory. Appropriate diagnosis of acute cough is rewarding. Again, I want to repeat it again and again. Don't just label it as a viral URI or a viral URI with cough. Try to pinpoint specific part of respiratory system what is involved, and I think that would make your prescription more rational and your treatment more rewarding. Antitussive they can be prescribed for distressing cough in children above 6 years. Again, there is some data they say, some data they disapprove. But I think the consensus is that try to avoid as much as possible. Don't use antitussive because trying to give symptomatic treatment to a child with respiratory infection, that doesn't make any sense. So I think we should refrain from using it. If somebody is using it, I think we can boldly try to stop those drugs, because what I'm seeing in my practice is that whenever I get referral from other doctors, I have to stop the medicine rather than starting any medicine. I stop those medicine which have been used in the past for this child, and definitely the child starts showing improvement. So try to avoid using all these drugs. So I think we have got some very important take-home messages. I like to thank all the panelists who have been on board till 10:50 tonight, and almost 772 delegates they have been on board. It has been an excellent day and excellent inputs from all of you, all the experts. I apologize to all the delegates. We cannot take the question because now already it's very late. My request is that please write all the questions to me. You can either mail it to me or you can put it on my WhatsApp. I'll refer it to all the experts. I'll take a view of all of them and I answer all of them. So I promise to do for all of you. Please WhatsApp me all your questions to my personal WhatsApp. I'll take all of them and I'll pass it on to the experts and we'll give you a proper answer for all of them. Let us hope that this discussion would make your management of acute cough in children more scientific, evidence-based, rewarding, and safe for all the children. So any last comment by expert, all of you? Kandu madam.
I think we've spoken a lot already, but if at all I use 3% normal saline, just a message that I would like to give, I would like to use in children like this. I've seen many of these wet cough which prolonged, and you use apart from hydration, you use 3% normal saline nebulization. Their chest, it clears like magic. Trust me, within 24-48 hours, these kids with wet cough will be better. And the message I would like to give is don't misuse cough syrups, especially in younger children. Be very judicious in what you use for them.
Thank you, madam. Sharma sir.
So, in my view, making a precise diagnosis is the cornerstone of your treatment of cough.
Thank you. Rashmi madam.
Yeah. So we should refrain from giving the clear-cut messages. We should write the diagnosis, and whatever diagnosis we write, we should treat that and not give symptomatic treatment for cough at all.
Excellent. Kananam sir.
So, sir, for acute cough, first we have to do the red flag signs that indicate the severe disease. Like it may be acute asthma, it may be some foreign body also, and it may be some this pneumonia also. So after ruling out this red flag signs, if it is typical viral infections, give the symptomatic treatment. Don't use this over-the-counter medications.
Thank you. Chidamba sir. Sir, please unmute Terry sir.
How is he logged in from Dr. Sanjeev?
Sir, please unmute kariye sir.
Wrong.
Sir, you are muted.
Yeah, I've unmuted. Thank you very much. I think I must thank all the panelists and Dr. Rawat for such a riveting 3-hour session. Thank you so much for bringing out all the problems which we face in practice almost on a daily basis. I will just end what my points are. My point is ultimately we have to keep the child comfortable. Whatever the diagnosis, you can diagnose whatever you like, but at the end of the day, the mother and the child must be kept comfortable. And for that, you must be very clear that you're not going to harm the child in any way by giving unnecessary medication. So that's my take. And important thing is, take care of the simple things. Those are the things that are going to make a lot of difference. See that the nose is kept clear. See that the head position is kept properly. See that the child is given adequate hydration. See that the child is kept comfortable. See that the child eats well, sleeps well, and the mother then will be happy. You can tell whatever you like, but build trust. Ultimately, it's very easy for us to say, don't give cough syrups. But the mother can go and, go to the next doctor and collect some cough syrup or go to the pharmacy and buy a cough syrup. They must have 100% trust in you. And for that, you should show that you're caring for a child at all levels. So I think this is my final talk on it.
Thank you very much. So on behalf of IAPNRC, I wish to thank you, all of you, all the speakers in previously, Dr. Mohite, Dr. Ankit, and Dr. Rashmi, and all the panelists for excellent session today. And hope that this session would do a lot in improving the cup management in India. Thank you very much. Good night and goodbye for IAPNRC. Good night to all. Thank you very much.
Good night. Good night.
Good night.